Good morning, Luis. How are you?
Good morning, Ray. I'm doing good. How are you?
Pretty well, thank you.
Thank you for this
Luis, how are you?
for this great job. Good morning, Ray. I'm doing good. How are you?
Pretty well, thank you.
Thank you for this. You're like an echo
Luis, how are you?
for this great job.
We are hearing an echo.
It's been taken care of.
Okay.
That was a live stream test.
How are you, Luis?
I am very, very good.
Good.
So we have 1,824 now signed up to attend today, registered. And that's just on the Hedron project. And Sean has like 500 and some going through Colorado. So it's going to be a pretty big crowd, maybe.
What's the number?
Pardon?
What was the number? 1,000 what?
824 right now.
With you?
With us, yes. And then you add 500 from Sean, 500 and some. I think he had 527 or something.
Mhm.
It's not bad.
No, could be worse. Let's see. Andrea,
Dígame.
after the welcome, I want to present you. And when you finish, you present me.
Sounds like a plan.
And then I present Mark. And then I present Arnold and Alberto, and then we have a break.
Okay. Okay. You're gonna present primary pull-through, trap, and errors.
Mhm.
Perfect. Let me get a paper. And then I will monitor questions in chat. Are we gonna have questions in chat in the room, right? I'm assuming we'll have.
Yes, the chat should be working this time around. I checked all
Okay.
that several times.
And then as soon as we finish the course, Luis, then I'll go to the hospital.
Okay. As soon as the course is finished, I'm going to my house.
Oh, you are?
Wow.
Seriously or no?
No, no.
Okay.
I'm joking.
Okay.
It's just back and forth.
Okay. No, it's because I have to stay here because of Alberto. Otherwise, I would be.
I know. No.
So we're about 10 minutes out. Does anyone have any problem if I start the webinar? We're in a testing thing right now.
No
No,
problems. I'll
Okay.
keep myself muted.
Okay, I'll do that right now.
yeah, I'm going to be mute. I'm ready, Ray.
Yeah, let's give one more minute for people. There's a lot of people still coming in. Just one more minute.
Yes.
I think we can start now.
Ready, Ray?
We're all set. Yep, thank you.
Okay. Good morning, good afternoon, good night, everyone. Welcome to this 2022 Hirschsprung course. The International Center for Colorectal and Urogenital Care has prepared this course with love, trying to be a good guest for you. In these times, in this crazy world, we want to share with you some hours of fun and education. So welcome everyone from all over the world. Already we have more than 2,300 participants in this meeting. So if everyone made one question, we will have more than 2,000 questions. And this is the most important in these conferences. We want to hear from you. What is your opinion, your question, your concerns about this amazing disease, which is the Hirschsprung course? I just want to share with you one of the main goals of this conference. Number one, all the team want to share with you our experience and philosophy about this entity. Number two, we want to recognize and share with you the current limitations that we have regarding post-operative results, even in technically well-performed operation in patients with Hirschsprung. In other words, even when we have new technologies, better histopathological diagnosis, beautiful operations, these babies, most babies, many babies with this problem, they continue having problems after these operations. Number three, advice to you on how to avoid traps and produce errors in the diagnosis and treatment of Hirschsprung disease. And finally, to explain our experience in the post-operative management of patients with Hirschsprung to improve the quality of life. As you already know, the operation in this patient is just the tip of the iceberg of the problems in these patients. Just to give you an idea about how many publications about Hirschsprung, just in English, just in children's, in PubMed, just in PubMed every year, you can see every year we have more and more and more. So every day we need to dedicate at least to read one paper published in English just in PubMed about Hirschsprung. So it's becoming more crazy every day. And when we look about papers, publication about constipation, the situation is worse because you need to read usually at least 2 papers every day from PubMed. So this is a constant problem that is moving every day. So thank you again, everyone. Now I want to introduce our first speaker, my partner, Dr. Andrea Bishop. Andrea is the director of the International Center for Colorectal and Urogenital Care. She holds the Poncio Family Chair for Colorectal Pediatric Surgery. She is full professor of surgery in the University of Colorado. Thank you, Andrea.
Thank you, Dr. De La Torre, and welcome everyone to the Hirschsprung course 2022. For me, we're gonna start with the newborn, what to do when you have or when you suspect that this newborn has Hirschsprung's disease. So you will probably be called from the neonatal intensive care unit or from the neonatologist because there is a baby with abdominal distension. In the classic history, this baby has not passed meconium for the first 24 or 48 hours of life. Our first obligation before sending the patient to radiology is to examine the baby. Let's see if the baby is truly distended, and we are looking here and we are seeing a distended abdomen. Second, let's confirm that the patient has an anus and that the anus is patent. So you're gonna look and then you're gonna get a small Foley catheter and try to pass through the anus to confirm that it is patent. And at that time, if you have passed the Foley, you're going to do the first essential maneuver, rectal irrigation. And this will probably decrease the abdominal distension. And throughout this course, you will see that rectal irrigation is one of the most important maneuver for patients with Hirschsprung disease. And we're going to emphasize multiple times because after this course, everybody should be very, very well trained on how to do rectal irrigations. So you're going to start rectal irrigations. You're going to keep the baby at least in 3 times a day, rectal irrigation, nothing by mouth, NPO, and keep the patient on flagyl, metronidazole. At this point, you have to tell the parents it may be Hirschsprung, it may not be Hirschsprung. We're going to start the investigation process. We have to remember that Hirschsprung is 100% a rectal disease, meaning if a patient has Hirschsprung, the rectum will be affected. And that is key of why we do rectal biopsies. That is the gold standard for diagnosis of Hirschsprung disease, regardless of which segment the patient has affected, has no ganglion cells. So in the most common scenario, we're going to be dealing with a patient that has rectal sigmoid disease, but there may be a longer segment all the way to the transverse colon or all the descending colon, or the entire colon may lack ganglion cells, and sometimes even towards the small bowel. In this course, we're not going to be talking about total intestinal aganglionosis because this is a completely different disease in which the pediatric surgeon has very low input. It's a terrible disease that patients end up requiring parental nutrition. Some end up with transplant, but the results are not good. So let's talk about the classic Hirschsprung. You're gonna do a rectal biopsy, either a full thickness or a suction biopsy and a contrast enema. With those two studies, you have the confirmation of the diagnosis and you will suspect the length of a ganglionosis. So the first thing to keep in mind is where we should take the rectal biopsy. So we have to remember that the anal canal is aganglionic. So if you take a biopsy too low, the results are not going to be real. Then every human being has this aganglionic portion, a hypoganglionic portion, and we should take the biopsy. We recommend around 2 centimeters above the pectinate zone, because that's the area where we should have normal ganglion cells. So when you're doing a full thickness biopsy in the OR, this is very predictable and you should target the appropriate zone. Now, if you're doing a suction biopsy, those are the most common machines to do the suction biopsy. One trick is just to measure how inside you should be and mark in the capsule where you should go, remembering that you have to target that area where the ganglion cells, absent ganglion cells, will be truly abnormal. We don't do suction biopsies if the babies are older than 2 months. I always do full thickness biopsies. So how we do full thickness biopsies, we consider this a real operation, not a minor procedure. Baby is in the operating room, general anesthesia. We put the baby in lithotomy position and we use this Lone Star retractor. We're gonna place initially at the mucocutaneous junction, and now you can see the anal canal. And now we're gonna advance the hooks further to protect the anal canal. So now we have protected the anal canal, we have the rectal mucosa, and we should aim to do the biopsy around here to be sure that we are in the right target area. The way we do it, we normally place a 5/0 vicryl suture in the upper limit, a 5/0 vicryl suture in the lower limit, and a 5/0 silk where my biopsy is going to be. We leave those two, the upper and the lower, with the needle because those are going to be our closing sutures. And this one will obviously go with the biopsy. So you have a completely immobile field. We have suction, we have the bovi, and we're going to use scissors and we are going to truly cut a full thickness biopsy. When I do my biopsies, I want to make sure the pathologist is happy with the amount of tissue that they get. So you really want to get full thickness. And then we're going to do a lower, a locking suture. So I go from the lower to the upper and then from the upper to the lower. And here is at the end of your biopsy, you want to make sure it's not bleeding and it is well closed. You're going to do a digital exam to make sure that you didn't cause any stricture as you did your suturing to close your biopsy site. And then you will have to decide between colostomy versus, in the most case scenarios, colostomy versus primary delayed repair. In order to answer which one you're going to choose, you actually have to go through several questions. How is the baby? Is this a single disease or the patient is a premature baby, has a cardiac condition? How is the baby responding to rectal irrigations? Do I get a very productive rectal irrigation and then a flat abdomen? Or the baby continues to be distending, it's not fully decompressed, the irrigations are not productive? How is the contrast enema? Is it suspicious for a low segment? Is it suspicious for a long segment? How far from the hospital do parents live? Do they live 6 hours from the hospital and we're in the middle of the winter? And if there is a winter storm, they cannot arrive on time? What is your surgical experience in transanal neonatal surgery? And very important, do you have good and experienced pathologists? And when we mention experienced pathologists, does your pathology have experience in diagnosing Hirschsprung disease, in analyzing intraoperative frozen section? Based on these questions, depending on the answer, you will know what to do. So if the patient is not responding well to rectal irrigations, or if you don't have a good pathologist, you should do a right transverse colostomy with mucus fistula and leveling biopsies at that time and wait for the results. And if you don't have a good pathologist, you can send the slides to a good pathologist and wait for the results. Once the patient has a stoma, the patient is safe. So we're going to discuss a few cases to give the example of what to do. So the first one was an 85 days old here in the United States, female patient with trisomy 21. She presented to the emergency room with a very distended abdomen and emesis. From the past history, she had the first bowel movement only at 7 days of life, and the contrast enema at that time led to the diagnosis of meconian plug. This is how the patient came to us. She was massively distended, extremely malnourished. So even in the simple abdominal x-ray, you almost can see a transition zone. So here's the contrast enema, and you can see this impressive contrast enemas only happen when the patient has, in most cases, a delayed diagnosis like in this one, because that means that the normal ganglionic bowel has been fighting the no ganglion area for a long time, and that's why this difference in caliber is so impressive. Because of how cachetic the patient was and the severe bowel distension, meaning that if I wanted to do a primary pull-through, I would have to resect all this distended bowel because I cannot do an anastomosis with such a distended bowel. We decided that this patient would benefit from a colostomy. So we did a laparoscopic right transverse colostomy with mucus fistula. So here you can see the colostomy, and the mucus fistula is right here hidden. And then after 3 months, the patient gained weight and we repeated the contrast enema. So you can see that that bowel that was massively dilated now has better caliber, and you can still see the difference in caliber from here to this area. So we started transanally, and here we are just at the mucocutaneous junction. Then we protect the anal canal, and we're going to start our dissection even deeper. So we place multiple 5/0 silk stitches, and in this case, we went to the abdomen and we found the transition zone. We do biopsies every 5 centimeters to confirm the level, and then we did the anastomosis. So this patient is now 5 years old. She's toilet trained for urine stool, but she takes senna. She takes laxatives, so 30 milligrams of senna every day. The importance of this slide is because even when patients have a technically correct operation, we cannot let them go. Many of them will suffer from enterocolitis, and I think my next case is about that. Other patients will need help with laxatives to stool every day. And in some patients, we need to add fiber and Imodium when we resect a lot of colon. So those patients, even the normal ganglionic bowel is not a normal bowel. They need follow-up even when they are doing extremely well in the immediate post-operative. because in the immediate postoperative, they may do well, but if they are lost to follow up, they will come back with severe problems. And if you continue following them, you will address them accordingly. So this was a term male newborn, completely different situation from the previous case. Around 20 hours of life, started refusing feeds and developed abdominal distension. Had not passed meconium yet at the time we went to examine the patient. This was the abdominal x-ray. We confirmed that the patient had the anus. We did rectal irrigation, kept the patient with nothing by mouth, and started flagell. Then we did a suction rectal biopsy and ordered a contrast enema. So here's the contrast enema for this patient, not as characteristic as the other one, but it seems that there is a difference in caliber between here and here. This one is not one that I would say 100% I know it's Hirschsprung, but in this case, we confirmed with the biopsy that there were no ganglion cells, there were hypertrophic nerves. The patient was discharged on rectal irrigations 3 times a day, and then he came back at 2 months of age and underwent a pull-through for Hirschsprung's disease. So this one was done all transanally. And the patient did extremely well in the immediate postoperative, but this patient had several episodes of enterocolitis during the first year of life. And this is the reason why I bring this case, because regardless of a correct operation, 30% of the patients will suffer from enterocolitis. And this is something we should tell parents before the operation, so when it happens, they are not surprised about it. So in our patients, parents have to learn how to do rectal irrigations before the operation, because in the event that the baby gets distended postoperatively, the parents are already comfortable on doing rectal irrigations, and they should start rectal irrigations before even bringing the patient to the hospital. This patient lived very close to the hospital, so family always come. And those are the abdominal radiographs when the patient presents with an episode of enterocolitis. So you can see a very distended colon filled with gas. And this is the X-ray immediately after the first rectal irrigation. Patient feels better immediately, and you can see the difference with a before and after irrigation image. Another episode, the patient came again, characteristic radiograph. You see this colon filled with gas in a patient with Hirschsprung. This is enterocolitis. When the patient is in another hospital, we tell the pediatrician, get an abdominal x-ray. If you see gas in the colon, it is enterocolitis, start rectal irrigation, start flagell. So this is before rectal irrigation, after rectal irrigation. Another time the patient came, same image, this colon filled with gas. That's the image before rectal irrigation, after rectal irrigation. He's now 6 years old, has 1 voluntary bowel movement a day, no more episodes of enterocolitis. The good news is when you had a technically correct operation, enterocolitis tends to go away. I tell families it happens more often during the first 3 years of life, especially when the baby is not toilet trained for stool, and then it tends to decrease. We never see, well, we should never say never in medicine, but it's very unlikely to see a teenager with enterocolitis. You see those very young patients. So this is another story, an 8-month-old male patient. He did not pass meconium within the first 24 hours of life, and he also received the diagnosis of meconium plaque. He did relatively well while he was on breast milk and receiving daily glycerin suppositories. But once solid food started, the patient started stooling every 2 weeks only. And that's when the mother said, this is not normal, I am done, because the pediatrician kept reassuring her that everything was fine. And she traveled throughout the country and came to Colorado and said, I am 100% sure that this is not normal. And she was right. So this is the contrast enema. Again, this is an 8 months old. So you can see that this baby has been suffering for a long time. And that's why we see this spectacular contrast enema in which we see the obvious difference in caliber. So this patient underwent transanal with laparotomy. And when we are doing a laparotomy for any pull-through, we have to really see the blood supply so we can decide which vessel we are going to ligate. So in this case, if we're going to try to bring this segment down, we can ligate this vessel very low, close to the base, and then we will be able to preserve the arcade. If you preserve this arcade, all this bowel will have good blood supply. So whenever we are doing a pull-through, we are not supposed to ligate close to the bowel. If this is the segment you want to bring, you want to ligate the base and preserve the arcade, and then you will have a well-vascularized segment. So here we ligated, and you can see that the arcade is well preserved, giving good blood supply. And now we know that this segment will reach. The way we know if a segment will reach when you are doing a laparotomy, this portion here that you want to bring down, you should palpate the inferior rami of the pubic bone, and either 2 fingers or 4 centimeters below the inferior rami. That means when you bring this bowel, it will reach the anus without tension. And I think this is my last case, a 39 days old female patient with rectal biopsy during the first week of life, diagnosed with Hirschsprung's disease. This is the contrast. This is the abdominal X-ray, and you can see a distended bowel here with difference in caliber, making it suspicious for a longer segment. So here you can see that this seems to be all the way that all the descending colon is affected. And here seems to be the dilated portion. And that's exactly what we found intraoperatively. So we started transanally, we protect the anal canal really well. And then in this case, we went for a laparotomy because we knew we would need a laparotomy. We did several biopsies throughout the case, and this was all aganglionic. And then we finally found the difference in caliber that you can see here. And we were able to bring healthy bowel down. And that's the contrast enema and the intraoperative imaging confirming that it was a long segment. And then you can see that we pull through and we have good blood supply at our anastomosis. And then what we do with a patient that has no colostomy, when we do the pull through, we keep the patient 7 days NPO on TPN, and then we observe the patient. Sometimes around day 4, 5, or 7, the baby gets a little distended. We get an X-ray and we see that we have gas in the colon. That's when we start rectal irrigations. And for my patients, I send them home in a protocol of rectal irrigations during the first month post-op, 3 times a day rectal irrigations, flagell 3 times a day. On the second month, I get an X-ray. If everything is fine, I decrease to 2 rectal irrigations a month, flagell 2 times a day. On the third month post-op, another X-ray. If everything is fine, once a day irrigation and flagell once a day. If in the last month, the patient is already stooling spontaneously, that's a great. If the patient is not stooling spontaneously, during this last month, I will start Senna because I want the patient to start stooling in between irrigations so we can eventually stop irrigations and just continue the laxatives. And one question that we always get from parents, because Hirschsprung disease is a disease that is not diagnosed prenatally. In most of the cases, there are rare cases of prenatal diagnosis. So parents get so concerned after this diagnosis, and they want to know, what are the chances of my next child having Hirschsprung disease, or what are the chances of my child passing to his or her child the same disease. So this is the best table that I have found about the percentages of siblings or future offsprings to have Hirschsprung's disease. So the way you have to look at the two sides. It depends on the length of a ganglionosis. So for example, if we have a patient, a male patient with a rectal sigmoid segment, the chances of another brother is 4 to 5%. The chance of another sister is about 1%. Now, if we have a long segment or total colonic ganglionosis, the numbers will be high. So if you have a male patient with total colonic ganglionosis, the chance of the sibling is about 9 to 12%. And the chance of their offspring, their children, is very high. So usually parents like to be counseled about that. And in the event that the mother is pregnant again, we tell that family to try to deliver in our hospital so we can observe right away if there is suspicious for Hirschsprung. We have very low threshold to biopsy the sibling. And this is a female patient, 1 day of life, and this contrast enema that it's very impressive for 1 day of life. We not always get this good contrast enemas that it's really revealing for Hirschsprung disease. Many cases we have contrast enemas that are not so obvious, and the biopsy and the clinical picture help us guide. So this is a patient that seems to be a rectal sigmoid Hirschsprung, and then you will have to make the decision. Is the patient responding to rectal irrigation? If the patient is responding to rectal irrigation, you can send them home with 3 rectal irrigations a day, flagell, and then schedule the operation electively, provided you have very good pathologists at your institution. And if the baby is not responding well to rectal irrigations, you should do a colostomy if you suspect a short segment, or an ileostomy if you suspect long segment. And if you don't have a good pathologist, that's when you should do the leveling biopsy and wait for permanent results before you resect any segment. Unfortunately, or I would say in our case, fortunately, because we have very good pathologists, this is a disease that we as surgeons depend on having a good pathologist. It has to be a partnership. And as surgeons, we should not remove segment if there is doubt, because once we remove, there's no way to give it back. Especially when we are thinking, I know tomorrow I'll be talking about total colonic ganglionosis, and it's when I'm going to emphasize this concept even more. I think in a short segment is not that important, but when you're talking about removing the entire colon, it's extremely important to be 100% sure about the diagnosis. So the partnership between the surgeon and a good pathologist. And remember, if you don't have a good pathologist, you should be able to get good biopsies, send somewhere else, and wait for results, and then do your operation. And with that, I'm gonna finish, and I'm happy to answer any questions that you all may have. Thank you very much. Is there any question, Luis? Okay, I see one question. What is the role of the donut biopsy? So we do the donut biopsy at the area where we're gonna do the anastomosis. So we do full thickness biopsies throughout the operation. And once we're gonna do anastomosis, then we send the entire circumference. So that's when we do it, just to be 100% sure. I think Dr. De La Torre already answered many of the
You have three already.
Okay.
Does irrigation before contrast enema affect the accuracy of diagnosis?
So we always do irrigation before the contrast enema. I always do, because I think irrigation is a life-saving maneuver. And the baby, if the baby has Hirschsprung, if the baby has the classic contrast enema, the rectal irrigation, in my opinion, will not affect the diagnosis. And the diagnosis is with the rectal biopsy. The contrast enema will give you a hint of the level. Do you dilate post pull-through? That's a good question. Post pull-through, I ask patients to come to clinic 1 month and I do a digital examination. If I feel the ring of the anastomosis, I tell patients to dilate. Different than anorectal malformation, I start anal dilations at 1 month, not at 15 days post-op. Do we need to biopsy all patients with presumable diagnosis of meconian plug? I don't think I know this answer, because I don't see all the patients with the meconian plug. I see the ones that are not doing well, or the ones that are really suspicious for Hirschsprung. I don't know how many patients are diagnosed with meconian plug, and that is a true diagnosis. So my dilation protocol is the same as the anorectal malformation. I start with a small Hager and I progress. The only difference is that I don't start at 14 days post-op. I start at 1 month post-op. What about leaving a rectal tube? I have not done yet, but Dr. De La Torre and I have discussed that option, especially in patients that are irrigation dependent, patients that really need, even with a stoma, they are needing irrigations despite having ganglion cells. I think it's a reasonable option. Procedure of doing donut biopsy. I'm not sure I understand that. As I mentioned, I only do the full circumference during the pull-through. When we're going to do the anastomosis, remember that picture that I showed, that the entire segment is pulled through. We just cut a circumference and send to pathology. How to explain the episodes of postoperative enterocolitis in patients with, I don't know what that means. There's a question about Botox before, during, or after surgery.
Okay, I
I
can
don't.
answer that later.
Okay, Dr. De La Torre will answer that later. We do the operation in prone position. Okay, I think I answered most. Is there anything missing? About skipped lesions, I have never seen a case of skipped lesion in Hirschsprung. So.
Yeah, there are many questions about postoperative care and everything. This conference was about how to manage the newborn and how to do the diagnosis. So be patient.
Okay, so I'm gonna introduce now Dr. Luis de la Torre, who doesn't need many introductions. He is my surgical partner. He helps me with our center. He is the assistant director for the International Center for Colorectal and Urogenital Care. He is well known for describing and teaching us all about the transanal approach to treat Hirschsprung's disease. And today he's going to talk to us about primary pull-through, trap and errors. Welcome, Dr. de la Torre.
Thank you, Andrea. Okay, again, good morning, good afternoon, good evening, and good night, everyone. Let's talk about primary pull-through, trap and errors. This doctor on the screen on the right side is Dr. Orvar Svensson. So Dr. Svensson describes the surgical principles on how to treat patients with Hirschsprung disease. These three principles still the same. Number one, you need to do the resection of all the aganglionic intestine. If it's the entire colon, you need to do a colectomy. This is very important in total colonic patients. Pull through the proximal intestine with ganglion cells. And then you need to perform the most perfect anastomosis, very close to the area where the dentate line is located. Remember, the anastomosis is not a coloanus, it's a colorectal. If you do a coloanus anastomosis, you are doing the anastomosis over this pectinate zone. So many years ago, Dr. Svensson described how to treat these patients. So he performed 3 operations. Operation number 1, he created a colostomy, usually in the right transverse colon, because in those days, he understand that Hirschsprung just create problems in patients with aganglionosis in the rectum and sigmoid. So it was safe to do right transverse colostomy. Today, this concept, we can discuss about that. Then he took biopsies of the colon. So months later, he already know the level of the aganglionosis. So he went back to the OR and he was able to do the resection of the rectum and the portion of colon without ganglion cells. So the proctocolectomy and then the pull-through. And then months later, he took again the patient to take down the colostomy. So this is the stage pull-through. Is valid nowadays? Yes, of course. These 3 operations are still valid today. If a surgeon does not have the resources to do a primary pull-through that we are going to discuss later, you can do and you can stay with this same stage pull-through. The most important is not if you do 1, 2, or 3 operations. The most important is the outcome of the patient. Remember, we are not talking about what surgeon treat Hirschsprung with less operations. We want to talk about surgeons that are doing beautiful and perfect operations. So the stage pull-through is a great option, still is a great option in many, 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 many hospitals, many countries. Primary pull-through. This is the first trap I think you need to know. You can read in many papers surgeons from all over the world talking about outcome after Swenson primary pull-through. And when you review the paper, 40 patients in this cohort had colostomy before the pull-through. So this paper is not talking about primary pull-through. So to understand primary pull-through means the patient does not have colostomy, does not have ileostomy. So no previous enterostomy. So the patient already has the diagnosis, you have confirmed diagnosis of Hirschsprung. You already probably know the length of the aganglionosis. And then you take the patient to the OR and you are going to do the proctocolectomy, the pull-through, and the anastomosis in the same operation. And you are not going to leave a colostomy. Primary pull-through is all this in one operation. If you are doing a different thing, because you decide to do the pull-through and then you say, I prefer to create a colostomy to protect my anastomosis, that's perfect. It's not a mistake. It's a safe procedure. But you cannot report, you cannot say that you are doing a primary pull-through. This is very important in the papers. What type of pull-through you can do without colostomy? Any of these, even more. You can do Revein, you can do State, whatever you want, but this is the most three commons: Swenson, Duhamel, and Suave. 3D operations worked perfect. The only thing that you need to do is a perfect operation. Perfect Swenson, perfect Duhamel, and perfect Suave. So if you want to ask which operation is better, none of them is better. None of them. You can do Swenson, Duhamel, and Suave, but you must perform a perfect operation. Remember that. The second trap is when a baby is in the emergency or is in the NICU, I mean, in neonatology, in the intensive care unit, or in any part of the hospital, and you are called because the patient has abdominal distension and it's a newborn, initially everybody immediately plays what you are seeing here in this slide: a nasogastric tube, an NG tube, and then the NG tube is not a draining, and the patient is still with the abdominal distension, and the patient looks not very good. So this is a very common trap. A safety procedure when you have a newborn with intestinal obstruction and you don't decompress, you don't have return from the NG tube like bilious or whatever is, the safety procedure is you need to have a catheter in your hand and you must introduce the catheter in the rectum. If you introduce the catheter in the rectum and you do rectal irrigations, irrigation means just to put some water. And in the last course in 2021, one of the surgeons clarified very clear this concept. Irrigation is just to put water in somewhere. So irrigation means you have to do colorectal decompression with a rectal tube using passive warm saline washout. So wash in, wash out. This is the same patient. Look what happened now. If you place the rectal tube, the patient is going to improve immediately. In the next following minutes, probably in an hour, is going to be another patient because the rectal tube is going to decompress the colon. remember, Hirschsprung is not a mechanical obstruction, so you can place a catheter. It's a functional obstruction, and the catheter is very important. And then you, in this conference, you are going to be full of irrigations. So
children born with Hirschsprung disease often suffer from enterocolitis. The best method for treating this condition is by flushing and emptying the colon with fluid, which is called rectal irrigation. You'll need the following supplies in order to perform a rectal irrigation: 2 small basins, a 60 milliliter syringe with catheter tip, and a silicone catheter. If your child is under 1 year old, a size 16 French Foley catheter should be used. And if your child is over 1 year old, then you'll need to use a size 24 French Foley catheter. You'll also need water-soluble lubricant and normal saline. Start by warming the normal saline. We recommend sitting the bottle in a sink of warm water, then testing the temperature of the saline on your wrist to make sure it isn't too hot. Pour the warm saline into a small basin, then draw up 10 to 20 milliliters using your catheter tip syringe. Position your child so they are laying on their back with their knees bent to their chest, or if they are bigger, with their knees bent with feet flat on a surface. Place the empty basin next to your child. Lubricate the top 2 inches of the tip of the catheter and insert it into the rectum. Gently push the catheter so it follows the curves of the colon. Insert the catheter approximately 4 to 6 inches. Pause for a moment to allow any stool or gas to drain out the catheter into the empty small basin. Connect the syringe to the catheter and inject the 10 to 20 milliliters of saline. Disconnect the syringe and let the saline and any stool drain into the empty basin. Advance the catheter about 1 inch and repeat the process until the discarded fluid is clear. Do not advance the catheter further than the wide divider port. It is important between each injection that fluid drains into the basin. If the amount of saline you inject into the rectum is more than the amount of fluid that returns to the basin, then there is extra fluid in the rectum. To drain the extra fluid, try moving the catheter in and out while twisting. If fluid still does not come out, then the catheter may be clogged. Pull out the catheter and flush with saline into the basin before reinserting. If you think there is still fluid in the colon, you can reattach the syringe to the catheter and very gently pull back on the syringe to draw out the fluid. Do not pull back on the syringe if you feel any resistance. It's important to record the amount of saline injected into the rectum and the amount of fluid that comes out. In a good rectal irrigation, the amount that comes out is larger than what went in. Once the drained fluid is clear, remove the catheter from the rectum and wash your supplies with soap and water, then set out to dry. The supplies are reusable. For more information, please reach out to the International Center for Colorectal and Urogenital Care.
very good. So if you want to do a primary pull-through, you must teach the parents how to do irrigation. So the parents needs to be experts doing irrigations before the pull-through. Another trap and error. When you do a primary pull-through without knowing the length of the ganglionosis, so you don't know the length. So you start doing a transanal pull-through, and then you take a biopsy, and it came back without ganglion cells, and then you are spending probably 2-3 hours, and you have a lot of traction, tension, and you start to be desperate with this patient. So in order to do a nice, beautiful primary pull-through, if you want to do a transanal approach only, you must have to do a beautiful contrast enema. So once you have controlled the colitis, you can do the contrast enema. And it was one of the questions. So we try to control the colitis, so the patient can go home, mom is going to feed the baby, and then the patient could come back anytime to the hospital when the colitis is resolved, and we can do the contrast enema. Doing a contrast enema in an acute event of colitis is not recommended. You are not going to catch the transition zone. And always, as you can see in this image, the lateral view is always better than the AP or frontal view. This is how we do the contrast study in this patient. So you can see, you can insert just a little bit of the catheter, no more than 1 centimeter. The patient is distended. Then this is the poop that is coming out, fluoroscopy, and look how's the difference between the AP and lateral views. This is in the very, very old times. This is an image that I made in 1995. So it's the same procedure nowadays. This is our current protocol for patients with Hirschsprung, with a new technology, so we can obtain beautiful image with less radiation, but it's the same principles. Lateral views before a primary pull-through. So again, another trap, if you are doing a primary transanal approach in a long segment or total colonic, please don't do that, because you are going to produce most probably many problems in this patient. So when you have a patient with all the colon aganglionic and the transition zone is in the ileum, this is not a case for a primary pull-through. Usually, primary pull-throughs are done in very early stage of life, newborns or in the first month. So you need to recognize the anal canal. If you are doing an open operation, if you are doing a laparotomy or any other open procedure, and you are doing Suave or Swenson, a safety plan to avoid damage of the anal canal, and we are going to talk more later, you must prolapse the rectum to recognize this area, which is very important in patients with Hirschsprung. The prolapse of the anal canal are going to allow you to perform a nice primary pull-through. If you are doing a transanal approach, you must place a good retractor, an rectal retractor. We use one that is called Lone Star. As you can see, it has these hooks. We place initially in the skin to recognize this beautiful area, which is the anal canal. This is the rectum right here, and from here to here, all this is the pectinate or dentate area. So the anastomosis should be done here. So you need to replace these hooks more proximally. Another trap nowadays is the transition zone. Dr. Michael Arnold is going to talk about this in a few minutes. So I'm not going to stop on this. If you want to do a primary, you have to possess experience doing this procedure. If this is going to be your first pull-through, you need to do it with someone else with experience. You cannot do a pull-through in a patient with the doubt of the question if the patient has Hirschsprung or not. Very important, for primary pull-through, you must have reliable pathology team. That this team should have experience doing frozen sections, good radiologists, and an appropriate hospital and organization and resources. So if you are not in these circumstances, I do not recommend to do primary pull-through. What is a reliable intraoperative frozen section? I just want to mention something about this because like a surgeons, most of the surgeons, they don't understand what happened with the pathology the pathologists have in front in the microscope a frozen section. A frozen section is this, okay? If the pathologists have a very, very good lab and they have experience doing very good frozen section, probably they can see these letters, you know. If the laboratory is not very good, they probably are going to see like this. So this is how to compare intraoperative frozen sections. So if the pathologists have experience, they can say, yes, the biopsy has an E, then an F and a P, and I'm almost sure it's a T, O, and Z. That's it, okay? If the pathologists, they don't have experience, probably they are not going to be able to see anything. Compare with a paraffin embedded section so you can see the difference. So just this slide is to give you an idea when we are talking about frozen sections. So it is not recommended, I want to say is contraindicated to do intraoperative frozen sections for the diagnosis of Hirschsprung. Frozen sections are used when we are already have the confirmation that the patient has Hirschsprung disease. And we use the intraoperative frozen sections in primary pull-throughs just to confirm the level of aganglionosis. Another trap is trying to do a primary pull-through in an old patient with chronic Hirschsprung or long-standing Hirschsprung. So you can see this through megacolon. Probably these are the cases that Harald Hirschsprung treated many years ago, or Bart Svensson, or many other surgeons, or currently in patients that live in other countries. Even here in the United States, we receive patients with Hirschsprung treated like constipation with polyethylene glycol for 2, 3, 5 years, and at the end, the patient is a Hirschsprung patient. So these patients are not suitable for a primary pull-through. Finally, I want to say, you need to respond to the following questions in order to do a primary pull-through. The patient has Hirschsprung, you need to have a good rectal biopsy. What is the length of the ganglionic segment? If the contrast enema shows that probably or confirm the image of total colonic ganglionosis, you are not going to do a primary pull-through. Then, is a good candidate? Not all the patients are good candidates for a primary pull-through. Why? Well, because the patient is not well controlled with irrigation, the parents, they don't want to do irrigation, the bowel is super dilated, the surgical team does not have experience doing primary pull-throughs, the group of pathologists, they don't have experience doing frozen sections. So I think in this situation, the patient is not a good candidate because the circumstances around the patient probably are going to produce more problems. What options do you have doing primary pull-through? We already said you can do Suave, Svensson, or Duhamel. You can do only transanal. You can use transanal plus an umbilical approach to do biopsies in a mini incision. You can do laparoscopy, you can do laparotomy, or open, you can do open. Any of these approaches you can use to treat in a primary or one-stage pull-through. A very common question always, when you do a primary pull-through versus a patient with colostomy, then the pull-through, and then the colostomy closure, is the same functional outcome? And the answer is no. Both have the same outcome. The only difference is that if you are doing 3 operations, it's more expensive. If you are doing 3 operations, probably the patient is going to have more adhesions, more possible complications from the colostomy or the colostomy closure, whatever it is. So it's the only difference. But the functional result, again, which is one and the main goal when we treat patients with Hirschsprung, is the outcome is the same. Thank you very much. If you have any question, let us know. I want to start with the Q&A. In patients with total colony, do you think it is necessary to perform pull-through and protective cecostomy at the same time instead of ileostomy? Thank you. I'm going to defer this question because we have a conference about total colonic, so Andrea can answer this one. How long do you wait to perform the contrast enema after the enterocolitis event? This is a very good question. If the patient came to the hospital and is a newborn and he already has, remember, Hirschsprung is a congenital problem. All the patients born with Hirschsprung, in consequence, all the patients have enterocolitis when they have 1 day of life or 12 hours of life. Mild, moderate, severe, or they have a perforation. So my recommendation is you need to think that the patient with Hirschsprung always has colitis, because once you see for first time the patient and you do the diagnosis or you have the suspicion of Hirschsprung, you need to treat the patient like a patient with colitis. At least 10 days with flagell, has already Dr. Bishop mentioned, and do irrigations. If the patient start to have yellow, seedy bowel movements like any other kid, that means the colitis is resolved. If the patient is still having diarrhea, full smelling bowel movements, the patient has colitis, even when it's not distended. So if the patient is already in very good conditions, is eating, is not having, is not vomiting, the bowel movements again are yellow seedy, the patient isn't ready for the contrast enema. So we don't have a time. Do we need to stop rectal irrigation before the contrast enema? Yes. I'd like to stop the irrigations 6 or 8 hours, sometimes 12, depends on the patient, to give time to the proximal colon to be dilated. Okay, if you do an irrigation and then right after you do the contrast enema, probably the dilated segment is not going to be accurate. So what I do is I keep the irrigations. If the patient needs irrigation every 6 hours, I stop at least 6 hours. If the patient is doing irrigation every 8 hours, I stop 8 hours the irrigation before the contrast enema. Yes, we use saline for the irrigations always. What do you think about biopsy before 3 months of age? If the patient, you think the patient has Hirschsprung, is indicated. We are going to talk about Hirschsprung versus constipation. Probably we can answer this question later. Yes, you can see the full video of a transanal pull-through, not edited, Swenson and Suave. So you can see this video online is free. You just need to go to YouTube channel and look for my YouTube channel. And we have in this channel many videos about how to do transanal pull-throughs with Suave and Swenson. And also you can visit the YouTube channel from Children's Hospital and the Colorectal Center, and you will see many videos about this conference. Okay, so let's move forward. And now I want to present our friend and expert pathologist, Dr. Mark Lovell. Dr. Mark Lovell is a professor in the Department of Pathology here in the University of Colorado at Children's Hospital. Is the director of the laboratory of this hospital, the medical laboratory. And he also works, obviously, in the Department of Pathology here at Children's. Mark, thank you for being here with us.
Thank you, Luis. And can everyone see my screen? Great.
Yes.
All right. Thank you. Thank you. Well, I am happy to be part of this symposium on Hirschsprung's disease, and what I'll be presenting this morning is a background of the pathogenesis of the of Hirschsprung's disease and the preoperative diagnosis. And I have no financial disclosures or conflicts of interest to report. And I have 8 learning objectives for this morning's presentation. The first, of course, a brief review of Hirschsprung's disease, followed by the team approach to diagnosis, as I think has already been emphasized, the genetic components that underlie Hirschsprung's disease, the development of the enteric nervous system, the histology and terminology around the rectum and the enteric nervous system, the decision to perform the rectal biopsy and the surgical handling that's necessary for that, then the laboratory handling of rectal biopsy specimens, and then finally the pathologic evaluation of those biopsies. So Hirschsprung's disease is obviously a relatively common disorder that we deal with. Approximately 1 in 5,000 live births have this disorder. And even with the advances that we have, depending, of course, on circumstances, mortality is still can be significant and often related to perforation of the intestine at 2 to 5%. Dr. Harald Hirschsprung was a Danish pediatrician who first recognized the presence of megacolon and described this disorder in the literature. But it wasn't until 60 years later that Dr. James Kernahan, who was a neuropathologist at the Mayo Clinic, recognized that Hirschsprung's disease was due to a congenital aganglionosis of the colon. Rectal biopsy, as I think you all know, remains the diagnostic gold standard for the diagnosis of Hirschsprung's disease. So again, this team approach to diagnosis is important because, as Luis has emphasized, we really need a specialist group of individuals to care for this patient, and that may begin with, of course, a pediatrician or neonatologist, or a gastroenterologist who's consulted to evaluate a patient who's not passing meconium or has some other abdominal distension or presenting signs. Of course, then the radiologist has to perform their portion of the procedure. The surgeon clearly has to obtain a proper specimen for evaluation, ultimately then by the pathologist. So it does take a dedicated team to get this right. One procedure that may be performed, for example, by a gastroenterologist would be anorectal manometry, and that procedure briefly involves inflation of a balloon and then monitoring the pressure to see if the rectal anal inhibitory reflex is present or is absent, as occurs in cases of Hirschsprung's disease. And I will confess, I don't know how often that's performed, but it is one way to evaluate a patient for this condition. Of course, Dr. Hayes will be discussing the radiographic assessment of Hirschsprung's in greater detail, but I just wanted to show the comparison between a radiographic image depicted here and that same specimen as we get it in a resection specimen. And obviously you can appreciate the dilatation of the colon here, and it's narrowing in this area. And then I will be talking about the initial diagnosis of suction rectal biopsies, and my colleague, Dr. Michael Arnold, will be discussing the intraoperative guidance of surgical management, particularly with serosal or full thickness biopsies, and then the postoperative evaluation of either primary or redo resection specimens. While I'm not going to dwell on this too much, I do think it's important to recognize that this field of study has benefited greatly from advances in our molecular genetic understanding of disease. And this, I'm not going to, as I said, go into any detail here, but there are specific genes that are involved in each phase of the development of the enteric nervous system, beginning with differentiation and then proliferation, migration, and then survival of the ganglion cells as they migrate along in the colon. While 70% of cases are sporadic, at least 10% have a positive family history of Hirschsprung's, and if they're looked for, about 50% of Hirschsprung's disease cases will have a genetic etiology, especially in those cases that show more involvement. There is typically a 3 to 4 to 1 male to female predominance, although this ratio becomes 1 to 1 in the long segment Hirschsprung's disease. Asian ethnicity also has an increased incidence, as I'm sure many of you know, and patients with trisomy 21, they represent approximately 10% of our Hirschsprung's disease cases, and 2% of patients with Down syndrome will have Hirschsprung's disease. And one particular mutation that I think is important to note is the RET mutation here, because RET mutations, as you know, are associated with a risk of multiple endocrine neoplasia type 2. So there is some import in understanding and evaluating the genetics of those patients. So the enteric nervous system begins, of course, during embryology, where we'll have somewhere between 400 and 600 million enteric cells that end up migrating, and these begin in the pharyngeal, or begin in the neural crest, and then move to the pharyngeal pouches, and then they will migrate from the esophagus at approximately 3 weeks, and then migrate toward the rectum, reaching that endpoint by approximately 8 weeks. There is a component of sacral neural crest cells that migrate to the hindgut and migrate in a caudal to rostral direction as well. But the principal migration, of course, is this migration from above. This schematic really shows quite nicely, I think, the complexity of this enteric nervous system. And here we have an appreciation for these multiple clusters and connections between those clusters within the wall, the muscularis externa of the colon, as well as then the submucosa with its, again, numerous clusters and interconnections. And of course, there are connections in between all of these structures, including up into the mucosas, we'll see momentarily. And again, while what we see histologically is relatively simple, as you'll see in just a moment, this is actually a very complex system with multiple neurons and interneurons that connect one to the other, connects with the interstitial cells of Cajal in the within the muscle that, of course, accounts for peristalsis. And so we are focused on, of course, the acetylcholinesterase secreting cells in these portions of the submucosa and in the Arbox plexus. So we'll look at that in more detail here. Just a brief review of the histology of the rectum. Obviously, we have a mucosa, submucosa, the muscularis externa, and within that, and then the serosa, and then within that, of course, Meissner's plexus and Arbox plexus. Looking more specifically at the histology of those areas, in the submucosal plexus, we have these small collections of ganglion cells that can be seen scattered throughout. And then in the enteric plexus or Arbox plexus, in between the two muscle layers, we can make out the distinct neurons. So these are the areas that we're going to be focusing on. Of course, with the suction rectal biopsy, we're looking just a subcomponent of that. We have our surface epithelium and glands, the spaces between those glands, which is called the lamina propria, and then the end of the mucosa, which is the muscularis mucosae, and then the submucosa, which is a loose connective tissue which contains vessels, lymphoid aggregates, and of course our ganglion cells and nerve fibers. Looking more closely now at the ganglion cells, you can appreciate that they can occur either in clusters or individually, and that these ganglion cells are characterized by an abundant cytoplasm, which is amphiphilic in nature, with a somewhat eccentrically placed nucleus with a prominent nucleolus, and then has often a satellite cell adjacent to it, a glial cell that's necessary. And there is a little bit of neuropil in this little cluster as well, as you can see. And one point I do want to make is these are nice and mature ganglion cells, but the challenge may come in a premature child where the ganglion cells are not as well developed and don't have these nice characteristic features which we rely on to make the definitive diagnosis of whether ganglion cells are present or not. So one thing that can trip up individuals that don't do this on a routine basis is that there are certain ganglion cell mimics that can confuse one if you're not experienced with this. One of these, for example, is seen here, in that here is a blood vessel with a plump endothelial cell, and someone in the desire to give an answer may misinterpret this as being a single ganglion cell. Similarly, histiocytes can be present in the lamina propria, and these again are somewhat larger cells with an eccentric nucleus and an abundant cytoplasm, but these won't have that characteristic open chromatin with the prominent nucleolus. So that's something, a trap to be aware of. And then lastly, of course, cytomegalovirus, which classically, as you know, has that sort of Alzheimer's nucleus in an enlarged cell. And that can, of course, be confirmed with the cytomegaloviruses with a specific immunostain. But again, these are some of the confusers that can enter into this problem. And so one really wants to have an experienced pathologist to work with you in diagnosis. So the decision to perform rectal biopsy has, of course, many inputs, and those start, of course, with the clinical scenario, the delayed passage of meconium, abdominal distension or intractable constipation, bilious vomiting, perforation. These are all symptoms that could suggest Hirschsprung's disease. Of course, we briefly alluded to rectal manometry and contrast enemas, and then the rectal biopsy itself. Things that might prompt you to consider biopsy even sooner are presence of Down syndrome or other syndromic Hirschsprung's findings, or a family history of Hirschsprung's disease, or as we'd already mentioned, certain high-risk genes, such as that RET gene that we spoke about earlier. So all of these inputs go into that decision to perform a suction rectal biopsy. So the important thing, which I think, again, has already been mentioned by Luis, is this issue around where to do that biopsy, which is critical for an accurate assessment. This illustration, of course, shows you with the yellow line, the pectinate or dentate line, and one wants to biopsy 2 centimeters above that region. If you're too low, you're going to get this squamous mucosa. If you're still not in the right place, you can get transitional epithelium, which is just interfacing here with some colonic glands. So we really want to get into the colon, into the rectum, and have this nice glandular mucosa, which we're seeing here. So how do we know if that biopsy is adequate? Well, first, we would ideally like biopsies that are approximately 3 millimeters in length, and we'd like at least 2 and preferably 4 biopsies to evaluate. Excuse me. Approximately a third of the biopsy should consist of submucosa so that we have an adequate amount of material to evaluate. And we don't want, as I mentioned, this squamous or transitional mucosa, because that would indicate we're too low. And it's also important to remember that if we're too low, we may be in a physiologically aganglionic region. Then when we get that specimen in the histology laboratory, we prepare it in a very specific way to maximize the opportunity to get a definitive diagnosis. So we at Children's Hospital Colorado cut at least 7 H&E slides with 15 levels on each slide, and we try to evaluate then 75 to 100 serial step sections. In between the 3rd and 4th levels, we'll take a couple of unstained slides in order to have material available if we need to perform any immunohistochemical studies. But this is a picture of one of those slides with all the step sections laid out across the slide. And this is really very helpful when we actually have to do the assessment, because we're able to then take a particular portion, and if we suspect ganglion cells, we can look at that same section in multiple levels to conclude with confidence whether or not those ganglion cells are present. Now, there are certain diagnostic features that are supportive of that diagnosis of Hirschsprung's disease. These, of course, most importantly include an adequate biopsy which does not contain ganglion cells, but other features that are helpful include the presence of abnormal nerves, because those hypertrophic nerves, which we'll see in a moment, are very often telltale. And then, of course, if necessary, supportive ancillary staining studies. So this is a rectal biopsy without ganglion cells, and since they're not there, I can't point them out to you. But of course, this is an adequate biopsy because we have an abundant amount of submucosa, and you'll note here a hypertrophic nerve. The presence of those hypertrophic nerves is an important and helpful feature, and by hypertrophic we mean nerves that have a diameter of greater than 40 microns. If these are present along with ganglion cells, this suggests we're in a transition zone, which Dr. Arnold will be telling you more about. So again, how do we compare and contrast? Well, here is a normal nerve fiber, as you can see, compared with a hypertrophic nerve fiber, which has a much greater thickness. In this case, it was 50 microns in diameter and has a somewhat tortuous course through the submucosa. So that brings it to our attention. And similarly, we can perform immunohistochemistry, and the abnormal nerve fibers will have a paraneurium which stains with GLUT1, and so that helps both define the diameter and give us confidence we're dealing with one of those hypertrophic nerve fibers. The ancillary stains that we perform are based on some of the functional components. As you all know, the nerves that we're dealing with are parasympathetic nerves, and hence acetylcholinesterase is the chief neurotransmitter there. What is perhaps more commonly used now is detecting the presence or absence of calretinin, which is a calcium binding protein that's expressed in neurons, and more recently choline transport protein, which is a cell membrane transporter for choline into those choline synthesizing neurons. This table just briefly depicts the findings one would have with these studies. The real challenge with acetylcholinesterase staining is that it has to be done on frozen tissue because it's an enzyme histochemical stain. And the finding in normal, as we'll see in a moment, is a fine fibrillar staining, but there's an increased and coarse staining when Hirschsprung's disease is present. In contrast, the calretinin shows on paraffin-embedded sections a fibrillar lamina propria staining, which is absent in Hirschsprung's and perhaps much less subjective than the acetylcholinesterase and choline transporter, which again is an immunohistochemical stain with fine fibrillar staining and then increased staining in the presence of Hirschsprung's disease. And just briefly, this is the normal staining with acetylcholinesterase compared to the increased staining in Hirschsprung's disease, and almost in an opposite way, the fine fibrillar staining that we see in a normally innervated rectum and its absence in Hirschsprung's disease. These positive stains represent mast cells. And then this contrasts the choline transport protein staining on both frozen and paraffin with the acetylcholinesterase staining. And here we can see that the staining when you have Hirschsprung's disease is more intense with both of those preparations. So when do we need to get a full thickness biopsy? Well, if we have an equivocal suction rectal biopsy where we don't have colonic mucosa because we were too low, insufficient numbers of biopsies, too few, insufficient submucosa for evaluation, too little, or rare or equivocal ganglion cells, or an equivocal calretinin immunostain. And so full thickness rectal biopsies may be preferred in the older patient as opposed to the neonate, and often a single biopsy is sufficient for diagnosis. Immunostains can still be performed, and then this can be done as a frozen section as the first step of a pull-through procedure. So in conclusion, a close collaboration with a team of specialists is best practice for care of Hirschsprung's patients. Hirschsprung's disease results from complex developmental processes influenced by multiple genes. Multiple clinical factors guide the decision to biopsy, and then histopathologic assessment requires thorough expert examination, excuse me, occasionally utilizing immunostains or a full thickness biopsy to establish diagnosis. Here are my references, and I'm happy to take any questions.
Please type in the chat, Q&A, if you have any questions, Dr. Mark Lovell. Okay, so we can keep answering the questions in the Q&A chat. Please try to use the Q&A chat because it's easy for everyone and everyone can see the answers. Okay, let's move forward. Our next speaker is Professor Michael Arnold. Michael is the medical director of Anatomic Pathology, Department of Pathology and Laboratory of Medicine here at Children's. And Michael is a passionate and a very just pathologist also with inpatient with Hirschsprung disease. I really appreciate your time, Michael. You are very busy. So go ahead, please.
Thanks, Luis. Were you going to share the recording?
We can do it that way. Yep. Why don't we do it that way?
That's fine. Yeah, let's do that. And as this is playing, I'll keep an eye on the chat. I don't hear the audio just yet.
Ray, we cannot hear.
As you know, Hirschsprung disease is an aganglionic segment of bowel that can extend for varying lengths in the colon. This can be short segments that just involve the distal rectum. Rewind that just a little bit, maybe. And it can also be longer segments with transitions either in the sigmoid colon, the descending colon, transverse colon, the ascending colon, and even rarely into the small bowel. And when you look at a resection specimen from patients with Hirschsprung disease, you can see there's a tonically contracted distal segment, a transition in caliber, and hopefully you'll have some more proximal bowel that looks grossly normal. And I want to talk a little bit about some very precise histologic definitions before we go any further. So the aganglionic segment, you should have aganglionic myenteric zone and submucosa. And in children less than a year of age, you should also have abnormal nerves. That is, nerves in the submucosa that are greater than 40 microns in diameter. A transition zone is defined as the area between the normal bowel and the aganglionic segment, where you have some combination of these abnormal features: absent myenteric ganglion cells, absent submucosal ganglion cells, with or without abnormal submucosal nerves. And you can have any one or any two of these features in a transition zone. The euganglionic segment is the normal bowel, where ganglion cells are present in the myenteric zone and in the submucosa, and the submucosal nerve diameter is unremarkable. So going back to this patient specimen, you might look at this and think that it's very easy grossly to identify the transition from the distal aganglionic segment to the normal bowel, and you actually might even suspect that it's a straight line between the euganglionic normal bowel and the aganglionic distal bowel. But in fact, there's a transition zone where you can see variable presence or absence of those abnormal features, not only around the circumference, but along the length of the transition zone. And we know this because of some very detailed studies that have been done by Raj Kapoor at Seattle Children's. If you take a resection specimen and embed the complete circumference of it at 1 centimeter intervals, you can map out where the bowel transitions from normal euganglionic bowel to the transition zone features and back to normal bowel. So by embedding a full face at 1 centimeter intervals, we can identify each of these three features: submucosal ganglion cells, myenteric ganglion cells, and abnormal submucosal nerves around the entire circumference. So when Dr. Kapoor did this, he noticed there was quite a bit of variation in the length of segment of transition zone that had some of these abnormal features, and that was not necessarily proportionate to the length of the aganglionic segment. And in fact, these three features seem to be independently distributed, with some rather long segments of aganglionic myenteric zone or aganglionic submucosa in the transition zones. And you can see that those don't match up necessarily. If you find myenteric ganglion cells, that does not mean that you're going to have submucosal ganglion cells at the same place in most of these specimens, and the reverse is also true. So when we look at how we think about a transition zone based on this work, we now recognize that the transition zone is variable both along the length and the circumference of the transition zone. And generally, in most specimens, the transition zone is about 3 to 5 centimeters in length. If you look at a number of resection specimens, as Dr. Kapoor did in this paper, and you look at the length of the aganglionic segment and compare that to the length of the partially aganglionic transition zone segment, you see that nearly all of these specimens fall at or under 5 centimeters in length. And there's a slight upward trend to have longer transition zones with longer aganglionic segment. So the impact of this is really important because the distribution of submucosal ganglion cells, myenteric ganglion cells, and abnormal nerves is effectively independent in the transition zone. So this has some really important implications for how we handle frozen section specimens from these patients to map out where the anastomosis should be created. And probably the most important implication is that several centimeters of bowel, generally at least 5 centimeters of bowel, should be resected proximal to a limited biopsy that identifies ganglion cells in either the submucosa or the myenteric zone. The alternative would be to take the entire proximal margin from the proposed resection site and embed that for frozen sections and ensure that no more than 1/8 of that circumference is aganglionic in either zone, and that if the child is under 1 year of age, that no abnormal submucosal nerves are present. So when we receive a specimen for frozen sectioning, what we'd like to have is at least 3 millimeters of tissue, something large enough in each dimension that we can orient it by looking at the surfaces, identifying the serosa, and making sure we're cutting perpendicular to the serosal surface. So if this piece of tissue looks more like a cube, that's going to be pretty easy. But if the piece of tissue looks more like a pancake, there's really only one surface of this that we're going to be able to cut, and that's the surface that's either facing up or down. So we're really going to be limited in how we can evaluate that specimen. So we want to see something that looks more like a cube. It's important to keep the specimen moist, but we don't want to submerge it because introducing too much moisture into the tissue can introduce frozen section artifacts as we freeze the tissue for sectioning. And ideally, we'll cut 8 to 10 levels of an adequate piece of tissue for examination. And if that's well oriented, we should be very confident that we can identify or exclude the presence of ganglion cells and abnormal submucosal nerves that the submucosa is present. So when we report the frozen sections, we want to talk about each area of the biopsy, the myenteric zone, the submucosa, and the submucosal nerves clearly and independently in how we report this back to the surgeon. So we want to talk about the myenteric zone, whether or not it's present or absent, and whether or not there's ganglion cells. Similar with the submucosa, do we have adequate submucosa? Do we have ganglion cells? And do we see abnormal nerves if the patient is under 1 year of age? Communication about uncertainty is also important as well. Some of these biopsies can be very difficult to orient. We may not see the zone we want to see very well, and we may need to say, hey, I need to cut more sections, sometimes cut through the block to make sure we don't have tissue to examine. An adequate seromuscular biopsy should have about 3 millimeters of the myenteric zone. And when we have the biopsy perfectly oriented, we've cut it perpendicular to the serosal surface, we should be able to see that the inner and outer muscular fibers stream in different directions that intersect at roughly a 90-degree angle. And where they intersect, this is the myenteric zone. This is the zone we're going to look for ganglion cells. And you can see at low power right here, here's a nice collection of them. And at high power, you can see these have all the features you'd like to see. They have abundant eccentric cytoplasm. Sometimes it has some darker hue at the edge, and the nuclei have prominent nucleoli, all the things that make us confident these are ganglion cells. I like to do a diff-quick stain when I do frozen sections. And really the important reason to do this is because you can do it very quickly. So if you take this section first and start to stain it, you can have a very good idea about the adequacy of how you've oriented the tissue, as well as whether or not you need to go further into the block, even before your H&E stains come off. But you can also identify ganglion cells in these stains because a diff-quick stain makes these ganglion cells cytoplasm turn very bright blue. And you can see it tends to accentuate that darker cytoplasm at the periphery of these cells. Similarly, when these cells are present in the submucosa, You can also see that their cytoplasm turns a nice blue on the diff quick stain, again, with accentuation of the darker staining at the periphery of the cells. So here's a really nice full thickness biopsy that includes the serosa, the muscularis propria, including the myenteric zone, submucosa, and the mucosa. And as you look closer, you can see, again, you're looking for areas where the muscle fibers intersect each other, and in that zone between them is a ganglion. You can see by the architecture and the nuclear features that these are ganglion cells. Here they are on the permanent sections, where you can see even better the nuclear detail with the nucleoli and the darker staining of the peripheral cytoplasm. Here's a nice frozen section from an aganglionic area, and you can see we have this nice long piece that's well oriented. You can see very clearly we have a good look at the myenteric zone. We have lots of submucosa to look at, but when you get higher, you can see there's really nothing here. There's no groups of cells that look like ganglion cells. When you do this as a frozen section of the entire circumference of the proximal margin, in a lot of these younger kids, it's small enough to fit it in one block. If you need to, this can be embedded in a couple different blocks, but really the thrust of this here is that you're seeing the entire submucosa all the way around the circumference of the specimen, and you're seeing the myenteric zone as well, all across the circumference. And you want to find less than 1/8 of the submucosa or the myenteric zone that are abnormal. So once we've identified ganglion cells on a small biopsy, surgeons should go at least 5 centimeters proximal to that location to take their anastomosis, or they can do their anastomosis at a level like this, where we found the submucosa has no abnormal nerves, ganglion cells are present, and ganglion cells are present throughout the myenteric zone across the entire circumference, with not more than 1/8 of this being abnormal. Once we've identified that level, we're next going to receive a resection specimen. And all the things we've talked about the variability of the transition zone have impacts on how a resection specimen should be grossed and handled. When we receive a resection specimen, we always want to take a complete face of this proximal margin, even if it's been done separately as a frozen section. This will be important to document the status of the proximal margin. It's also very useful to take at least one longitudinal strip so that we can map out the distances of aganglionic, transition zone, and normal bowel across the length of the specimen. These recommendations actually went into a publication a couple years ago that included myself, Raj Kapoor, and several other pediatric pathologists. And Raj and I did a video that you can find on Twitter. If you search for hashtag Grossin90, you can find this video about how to handle a specimen. This will show you all the steps we just talked about. I'll also note that for redo pull-throughs, for things such as a duomel, it's useful to take 2 strips on either side of the bowel to help map out that more complicated anatomy in greater detail. When we report the results of a pull-through specimen, there's several aspects of the specimen that we're going to need to describe in our report. Importantly, the proximal margin status and whether or not there's ganglion cells in the submucosa and the myenteric zone around the entire circumference, and the diameter of the largest submucosal nerve are going to be very important for confirming that we've had a complete resection of all the abnormal bowel. We'll also be able to describe, based on that longitudinal strip that we took, the length of the aganglionic segment, the length of that strip that represents transition zone, and the distance from that transition zone to the ganglionic proximal margin. So thank you for your attention. I'll be happy to take any questions. Awesome. Thanks for playing that, Luis. I've seen a couple of really good questions come up.
Go ahead, Mike.
Yeah, I've seen a couple of really good questions come up in the chat and the QA. So let me see if I can get back to those because they bounced off on me here. What's the number of ganglion cells in a normal, in a ganglion in a normal bowel? It's usually about 4 to 8. Really, that's not, when we're talking about the intraoperative evaluation, that's not the most important feature to look at. We're just looking for any definitive ganglion cell, because we know that transition zone is going to be typically less than 5 centimeters. So if we're able to identify any definitive ganglion cell on a frozen section, that's what we want to report as positive, knowing that we're going to be able to tell the surgeon that they should go at least 5 centimeters proximal to that to take their anastomosis. How do you have circumferential frozen section biopsy? So in a smaller kid, in a neonate, like the section that I showed in the video, you can often get the entire circumference of the bowel to fit on a one block. Now, if you can't, you can certainly divide it between a couple blocks. But what's helpful to have in one block is that you can get a much better sense of where kind of 1/8 of that circumference is, how long 1/8 of that circumference is, so you can identify definitively that no more than 1/8 of that has a segment that lacks ganglion cells in either zone. And of course, you don't want to see any submucosal nerves that are larger than 40 microns. Comment on skip segments in Hirschsprung disease. Yeah, so I heard this question earlier, and I think this is a really unusual problem to have, but it is a real problem. And what most commonly happens when you have this, it's again pretty rare, but when it happens, what you're going to excuse me, what you're going to find is that you have an island of ganglion cells in the submucosa or the myenteric zone that are distal to the transition zone. So you're going to have just kind of this group of ganglion cells that are off all by themselves. That becomes a problem if you happen to hit that zone with one of your mapping biopsies for your leveling for frozen sections. If that does happen, you could find that you end up in the transition zone when you go proximal to that for the pull through, which is one reason why it's helpful to do the donut, because those islands of ganglion cells are generally not going to be completely circumferential, as they've been mapped in a couple of specimens that have been reported in the literature. So if you have a complete evaluation of the proximal circumference at frozen section, that's going to avoid that fairly uncommon pitfall. In patients with megarectum secondary to poorly managed chronic constipation, can biopsies be mistaken for Hirschsprung disease? And does histochemistry not allow this mistake? So I think what you're getting at is that in patients with constipation, you're going to have reactive hypertrophy of the submucosal nerves. And I'm related to one of the QA questions about how you have absent, when you have absent ganglion cells, how can you have hypertrophied nerves? So nerve hypertrophy is a reactive process. It's independent of where the ganglion cells are. And so when you have someone who's chronically constipated, the distal rectal nerves are going to become enlarged. And the reason you're not going to mistake this for Hirschsprung disease, if it's somebody who's just constipated, is because you're going to find ganglion cells in that. And that's really going to be the primary way that you're going to make that distinction. The changes in the nerves, the hypertrophy is going to have similar, could have similar cholinesterase and calretinin changes, but the calretinin is going to track really with the presence or absence of ganglion cells. So really what I mean to say is the acetylcholinesterase and choline transporter. The calretinin is going to track with the presence or absence of ganglion cells. I think there was another question that was asked earlier about how can you have an aganglionic distal rectal biopsy and have no nerve hypertrophy? If you see that, I would suspect that clinically you're concerned about total colonic aganglionosis. In total colonic aganglionosis, and I think we'll talk about this a little more in the course later on, when you have long segments of bowel that lack ganglion cells, that's a case where you may not see the hypertrophic nerves in the very distal rectum of a young child. But the absence of ganglion cells should warrant the further investigation, and hopefully the clinical and radiographic findings would point you towards total colonic. Formaldehyde is a component of formalin. So formalin is a buffered solution that includes formaldehyde. Let me see if I have a couple other chat questions here. I think this one might be for you, Luis, the duration needed between protective stoma creation and closure.
Yeah, there is another question, several questions about what to do when a pathologist report in a biopsy, in a rectal biopsy, for the diagnosis of Hirschsprung, and the pathologist report immature ganglion cells.
So immature ganglion cells is usually much more related to the patient's age. I think it's exceptionally rare. I really have never seen a case, and I think there's only a very, very small number of cases reported in the literature where the actual development of the ganglion cells is abnormal for some reason. But so I think the answer to that question, really in practice becomes, if you have ganglion cells, you're not dealing with Hirschsprung disease. And I also think too that you should follow up with the pathologist about this to see if they're trying to communicate some uncertainty about a frozen section diagnosis. If you are doing frozen sections on an 33 weeker who's only been a couple weeks postnatal, immature ganglion cells, immature meaning they don't have the normal amount of cytoplasm, but they have some of the good nuclear features, that's going to be normal. And what's going to be really helpful in that circumstance for the pathologist is to identify the architecture, because even at 36, 37 weeks gestation, those ganglion cells are still arranged in groups in ganglia. So that's probably going to be the most helpful feature to identify. So I think you just want to have some clear communication about what the pathologist is trying to convey to you. Are they trying to tell you they think something is wrong with the ganglion cells, which is really unusual, or they think that they're just finding them in a patient who's ex-preemie and they have some uncertainty about the identification. Punch gun biopsy compared to suction biopsy, differences in the results. I don't think I've ever seen a biopsy done with a punch gun. Luis, is that something you've ever used?
No.
Yeah, I can't really comment on
But
that.
just to be clear, if you observe in a biopsy immature ganglion cells, you can rule out for sure Hirschsprung, correct?
Correct.
Okay, it's just
Yeah.
to enforce this idea.
Yeah.
Then there is another question about the hypertrophic nerves. If it says, in case of Hirschsprung disease, where there is absent ganglion cells in this segment, how can they have hypertrophic nerves?
So the nerves that we're seeing in the rectum that are hypertrophic are extrinsic nerves that are growing in from outside the bowel. And that's a reactive process that's happening because that segment of bowel is aganglionic is probably the best explanation I have for you.
Totally agree. What do you think about, there's another question, what do you think about to take a biopsy of the rectum in a patient for the diagnosis of Hirschsprung on frozen sections? What is the risk to do a frozen section just for diagnosis?
Yeah, so that's thankfully a very unusual circumstance because it's not as easy to identify the ganglion cells on frozen sections as it is on permanent. And that's not just because of the frozen section artifacts. It's also because, as Dr. Lovell showed you earlier, when we look at these on permanent sections, we cut ribbons of the block and we get about 15 levels to a slide, and we look at 75 to 100 levels. That is very, very difficult technically to accomplish on frozen sections. So generally on frozen sections, the most I've ever looked at is probably about 20 to 25. And that's on something where I was really digging into the tissue and doing a lot of work because I had some uncertainty. Typically, we're going to look at probably 6 to 7 levels on a frozen section to be confident there's not ganglion cells. So I think the sensitivity of frozen section could be a little less for primary diagnosis. But I think the other important reason too is that we want to have that supportive ancillary stain. We want to have a calretinin stain that's negative to help us confirm that it's Hirschsprung. And we're not going to be able to get that on frozen sections. Some laboratories, very few laboratories, will perform acetylcholinesterase on frozen tissue, but that's a pretty unusual circumstance that a laboratory has that technical capability. It's really disappearing. So I would really recommend, if you're trying to establish the diagnosis, you want to have a suction rectal biopsy that's examined on permanent sections, looking at 75 to 100 levels with an ancillary stain before you start going to do frozen sectioning to determine the level. The frozen section should really be used to determine the level of the transition and not establish the diagnosis.
There are two more questions, please, Michael.
Sure.
There are at least 3 questions related with hypoganglionosis. So when a surgeon is looking for Hirschsprung and the biopsy of the rectum of any place in the colon, the pathologist report few ganglion cells, hypoganglionosis. What do you think? What should be the response for these surgeons?
So let's think about this in two contexts. First, in the context of frozen sections, a patient already has a well-established diagnosis of a suction rectal biopsy that showed Hirschsprung disease. And now you've gone to do a frozen section and you've gotten some feedback that, hey, that I only see isolated single ganglion cells. That's a pretty typical feature of the transition zone. So that just means you're getting near the euganglionic bowel. In a suction rectal biopsy, I would handle that with a lot of caution because as Dr. Lovell described earlier, the distal centimeter of the rectum is physiologically aganglionic. And that's someplace that I feel like you can also see isolated ganglion cells. So I think if you see a ganglion cell in a suction rectal biopsy, you can exclude Hirschsprung disease based on the presence of even an isolated ganglion cell. And I think that's probably the most you're going to be able to do. If you really, I think the cases of what's described as intestinal neuronal dysplasia are very few and far between. And I think they're really uncommon. So I think ultimately I would just use the suction rectal biopsy to exclude Hirschsprung disease. And I think if you're thinking about something else, you may need additional biopsies, say a longitudinal strip taken from the rectum so that you can really map out how close am I to the dentate line, how high above the rectum am I, and what does, once I'm confidently 2 centimeters or so above the dentate line, what does the ganglion cell architecture look like there? Does that make sense?
Yeah, clear, perfect. What do you think, or what is the meaning of a rectal biopsy for diagnosis of Hirschsprung, where the pathologists report absent ganglion cells, but positive calretinin?
Right. I think the first question I would ask is how many levels were examined. As I said, you can have that distal segment where that distal centimeter, if you sample that, you're not going to see the squamous or transitional mucosa, but you may see kind of that abnormal, ish hypoganglionosis. You may see isolated ganglion cells. And because you can see isolated ganglion cells, that's why we cut 100 levels of some of these biopsies, because you may only see a ganglion cell in 1 or 2 levels out of 100. So if you've only examined 25, you may miss that ganglion cell, and then you'll do the calretinin and see that it's normal, because the calretinin can be positive up to 1 centimeter away from a ganglion cell. So the calretinin is a much more sensitive marker, and I think that may just reflect that you haven't examined enough levels to find the ganglion cells are there, and it's very unlikely that I think that kid has Hirschsprung disease.
Okay.
Ultra short segment Hirschsprung disease, it does happen. It's not super common, but it does happen. And it's definitely something to be aware of.
Okay. You can keep doing questions and Michael can answer in the chat. Thank you so much, Michael.
Thanks so much.
Thank you. So we are going to move forward now. Dr. Alberto Peña, I think we don't need to present this speaker, but I want to say it's a privilege to work with Dr. Peña for many years. Now, Dr. Peña is the Emeritus Professor of Surgery in the University of Colorado and the former director and founder of this International Center for Colorectal and Urogenital Care. Dr. Peña, thank you so much.
Thank you very much, Dr. De La Torre. Good morning, everybody. It is a pleasure and a privilege for me to discuss a little bit about surgical history of Hirschsprung disease.
Alberto, you are muted.
Then I'm going to say again, thank you. Good morning, everybody. It's a pleasure for me to be present. Thank you, Dr. De La Torre. I'm happy to discuss a little bit about the history of Hirschsprung disease. In this photograph that you see is Dr. Frederick Reusch. in 1691, he presented a case that perhaps a patient who died with a very distended abdomen, and people suspect that that baby could have Hirschsprung disease. Nobody knows. We are not sure about that. For some reason, this doctor is not frequently mentioned in the literature. We refer to this disease as Hirschsprung disease rather than Ruiz disease. But the fact is that Hirschsprung himself presented a
Again, you are muted.
Well, hold on 1 second. Hold on, it's not working. Andrea, no order that they receive.
Sorry. Okay.
Nomás aquí. As I was saying, we all refer to this disease as Hirschsprung disease, and actually Dr. Hirschsprung, without taking any merit from his contribution, he presented a case of a child who died with a very distended abdomen and very dilated rectal sigmoid. So, but there is no mention of ganglion cells, aganglionosis, or anything like that. So, but anyway, he deserves that credit. He presented that in Berlin in a Congress of Pediatrics. In 1898, a doctor by the name of Treves suggested that perhaps these patients could improve or be cured by resecting the sigmoid and the rectum without any evidence, any basis for histologic basis. He just suggested that that would be the treatment, and as you know, in retrospect, it is the treatment, but there were no guidelines at that time. And it was in 1901, Dr. Teitel, who first mentioned of the possibility of absent ganglion cells. And that's that, however, it was just a mention, a suggestion, but it was not considered like an evidence. But anyway, he deserves that. And then a doctor that is very rarely mentioned in the literature is Alberto Dalla Valle from Italy in 1920. He really described the absence of ganglion cells in the distal column. For some reason, he's not frequently mentioned in the literature. There, as I will show you, there were two other pathologists in 1948 who are considered the pioneers in the diagnosis of aganglionosis. In this photograph is a photograph that I like very much because this shows the history of pediatric surgery, at least in the United States. This picture was taken in the backyard of Boston Children's Hospital, where I have the privilege to be trained between 1969 and 1971. When I trained there was still that backyard, the same way that it looks now, that looks in this picture. In the back, you can see a Harvard Medical School. And this doctor is William Ladd, which is considered the pioneer of pediatric surgery, at least in this continent, because in Europe, there were some people doing pediatric surgery. And here you see a doctor by the name of Orvar Svensson. Orvar Svensson at that time was a young fellow at Boston Children's Hospital. And in the extreme here, you see Dr. Robert Gross. Robert Gross was the successor of Dr. William Ladd. Dr. William Ladd was the chief. Dr. Gross would be the next chief because Dr. Gross performed the first ligation of the ductus arteriosus and the first repair of a coarctation of the aorta, and that made him a celebrity. And when Dr. Ladd retired, Dr. Gross occupied that job. Dr. Gross was a few years older than Dr. Svensson. And when Dr. Gross became the chief, Dr. Swenson went to work to the basement of the hospital because colorectal problems, defecation problems have never been a priority in medicine. It's a subject, by definition, is not elegant. So he was sent to the basement to work with these constipated patients. And that's where Dr. Swenson conceived what is considered the gold standard of the basis of the treatment for Hirschsprung disease. Eventually, Dr. Swenson moved to a hospital called Floating Hospital in Boston, which was a floating hospital in a ship, and then from there to Chicago. And then he became famous because he was the pioneer of the treatment that is considered the principles of the treatment, the basic principles. In this diagram, very, very simplistic, you can see the area of aganglionosis, the dilated colon, and what he considered was the treatment, which is resection of the aganglionic segment and pull through of the normal ganglionic bowel. This concept expressed in this diagram is still valid nowadays. But of course, the way you do this has went through several modifications through the years. Here you see Dr. Orva Swenson. I got this picture when he attended one of his last meetings, and I had a conversation with him. He was a very friendly individual and very smart, obviously. And in the left side, you see a diagram of the basis of his treatment. Basically, Dr. Swenson entered through the abdomen and dissected the aganglionic segment of the bowel all the way down to the anus, and then exteriorized that bowel and resected it. So the problem at that time, when he published that in 1948, a lot of doctors tried to imitate, to reproduce the operation of Dr. Swenson, and the problem was that you have to dissect the rectum in through the pelvis, and the rectum below the peritoneal reflection is anatomically related with very important structures. It's related with the posterior urethra, the bladder neck, the ureters, the prostate, seminal vesicles, vas deferens, and the nerves that give sexual function to in the male. And therefore, if you are not careful, if you don't follow strictly the principles that Dr. Swenson followed, which is to remain as close as possible to the rectum during that dissection, you are under the risk of injuring those important structures. And actually that happened. People who try to reproduce Dr. Swenson operation frequently had that kind of complications. And therefore, I had the privilege of meeting Dr. Swenson after I finished my training at Boston Children's. And in Guadalajara, he was invited to a meeting and we had conversations. And I showed a movie of an abdominal perineal put through for anorectal malformations, and he didn't like it. He said, "Is that what you learned in Boston?" I said, "Yes, that's what I learned." He said, "Well, they didn't teach you well," he said. But anyway, he was very friendly, and we continue our relationship for many years. In 1948, in Boston, Dr. Swelser, Wilson, Whitehouse, and Kernohan discussed in a very serious matter and presented evidence that the disease was provoked by the absence of ganglion cells. They are well recognized for that contribution. Now, in an attempt to avoid the complications secondary to the damage of the neighbor structures of the rectum, Dr. Bernard Duhamel from Paris, France, designed a very ingenious technique. What you can see here is he decided to leave the aganglionic rectum in place. So he didn't dissect the rectum. And by doing that, he tried to avoid damage to the bladder neck, to the prostate, seminal vesicle, etc. And rather than doing that, he decided to go through a safe path in front of the sacrum, a safe path all the way down to the lowest part of the rectum, and make a window here between the rectum and between the pull-through normal ganglionic bowel and the remaining aganglionic rectum. So, and he did that with two clamps that he left hanging in the patient until it produced necrosis, and then there was a window between the pull-through normal ganglionic and the aganglionic rectum. And I was at Boston Children's Hospital when he presented that technique. When he went to present that to Boston and other places, and a little shortly after that, it was Dr. Franco Suave who presented another way to avoid the damage that of the neighbor structures of the rectum. And what he did is to take a safe plane, dissecting only the mucosa, and went through the abdomen in the surgical, natural surgical plane between the mucosa and the seromuscular, and dissected all the way down. And by doing that, he guaranteed that he would not injure those important areas like the bladder, neck, etc. As I was saying, I was at Boston Children's, and I had the opportunity to see both techniques performed by different surgeons. Those surgeons who were kind of rough surgeons, you know, I like to talk about meticulous surgeons and rough surgeons, and that's something that I believe is genetical. Some surgeons are very tough, they are not meticulous, and they should be doing the big procedures. And there are other surgeons that are very meticulous and delicate. Those professors of mine who were meticulous like more the Suave procedure. And the surgeons who like to finish quick and they try to be very simplistic and rather rough, they perform the Duhamel procedure. Now, the problem is that later in time, we saw in these patients of Dr. Duhamel that these ganglionic segments started becoming dilated and accumulated stool. In other words, the stool that came through the normal ganglionic bowel came into this aganglionic segment. Part of the stool came out and part accumulated here, forming a huge mass of stool that produced symptoms and problems. Also, some people modify this technique by making this little window a huge one, so from here to here. Particularly with the use of staplers, you can make a big window and trying to avoid that pouch. But anyway, that was the problem. So the advantage of the technique, Duhamel technique, is that we didn't see many patients suffering from fecal incontinence. Most patients have preserved fecal continence, which is very, very important. The inconvenience is that that piece of aganglionic bowel accumulated a lot of stool, and that gave symptoms later that required a full reoperation. Now, in the case of Franco Suave, we didn't see injuries to the bladder or bladder neck unless you really got lost in that area. But it required a meticulous and delicate technique, and had some significant number of cases with fecal incontinence. I had the privilege of meeting Dr. Franco Suave. Here you see me in a meeting in Venezuela. This is Franco Suave, and this is me. And at that time, it was before I designed the posterior sagittal approach for unrectal malformations. I was invited to talk about other subjects, including Hirschsprung disease. And we had a few conversations. He was a very nice, very educated gentleman. And later, I was invited to Madrid after I designed the posterior sagittal approach. So Dr. Franco Suave, you can see him here, was also invited. And in one operating room, I was repairing an unrectal malformation. In the other operating room, he was doing a Hirschsprung disease. So at some point, I left my operating room and went to watch him doing the Suave. And then at some point, he left the operating room and came to watch me doing the posterior sagittal approach. And then we had lunch together and had a lot of conversations. And I said, Dr. Suave, I think I do Suave techniques better than Suave himself. He didn't like my but actually, even when he was very elegant, that submucosal dissection, what he did in those times is to pull through the normal ganglionic bowel through the seromuscular cuff and left the colon hanging out. So that was rather disgusting. So the patient stayed there and they post up in the floor with a piece of bowel coming out, smelling bad and with flies. And after 1 week, once he had evidence that there was no ischemia and necrosis, he took the patient to the operating room again, resected the part of the bowel that was hanging, and performed the anastomosis. I thought that was kind of at that time, I was already doing the Suave procedure, but without leaving the piece of bowel hanging out anyway. So, and then in 1998, Dr. Luis de la Torre, who is the director of this course, made a significant contribution describing the transanal approach in following the submucosal principle. You can do it both ways, submucosal or outside the bowel, but he demonstrated that you can do the entire procedure transanally, which makes a significant contribution in the benefit for the benefit of the children. Now, to make that kind of contribution is not easy when you live in a country like Mexico. And he was meticulous enough to try the technique first in animals, and to do in animals in a country with no resources and with very little academic support requires a lot of dedication and character and effort. And he did that, and then once he demonstrated that it was possible in animals, he did it in patients. He used to work in the same institution where I work in Mexico City, but in 1998, I was already working in the United States. Let's remember that about 80% of the patients with Hirschsprung disease have the ganglion, the transition zone, in the level of the sigmoid colon. That means that at least 80% of the patients can be operated transanally using the Dr. de la Torre technique without opening the abdomen and without laparoscopy. That's a significant contribution. And only in those patients with a longer segment, you have to open the abdomen and do laparoscopy, whatever you are accustomed to do. So we are in debt with Dr. de la Torre, and now it's a privilege to have him working in Denver. So we met in Mexico, obviously, before he came here, and then he was recruited to go to Pittsburgh, and now he works with us. It's a privilege. In 1999, Dr. Keith Georgeson, described the first primary laparoscopic assisted endorectal pull-through for Hirschsprung disease. And of course, laparoscopy came to stay, and every time we have to open the abdomen in a patient, we have to consider whether or not we can use a minimally invasive approach like Dr. Georgeson. Now his approach has been popularized, and a lot of people is doing the same thing. A few words about something called ultra-short Hirschsprung disease. This is I'm by nature, I'm a skeptical individual. And it was a skepticism which induced me to surgically explore patients with anorectal malformation, looking with the specific goal of seeing the real anatomy of the patient. Because before 1980, we were operating these patients without knowing the real anatomy. And I was not convinced, because nobody ever showed me a picture of a real picture of the anatomy of those patients, because those patients were approached to the abdomen or from below, and nobody saw exactly how the rectum joins the urogenital tract. And because of that skepticism, I decided to open the patient like that. And skepticism, I'm talking about healthy skepticism, is a source of creativity. All those who made real significant contributions, including Galileo, Darwin, Newton, and Einstein, and many others, they were skeptical about what was written at that time, and they decided to explore other possibilities. So I'm very skeptical about this diagnosis of ultra-short Hirschsprung disease, because at present time, I don't see a realistic, objective way to differentiate ultra-short Hirschsprung from idiopathic constipation. Most people who support this kind of diagnosis, ultra-short, are based on manometric studies. For several years, we perform manometry in our patients, and I become convinced that rectal manometry is useless. I'm going to repeat it in case somebody didn't hear me. I believe that rectal manometry doesn't provide any information that helps us in the management of any kind of patients. Because if you really perform that and you are honest in what you see, you don't see any. When you perform some studies in patients, it's because you expect that the results will help you to make decisions, like the biopsies in Hirschsprung disease. But rectal manometry is totally unreliable from my point of view. When you do rectal manometry, you inflate a balloon in the rectum, and that produces a relaxation of the so-called internal sphincter. Nobody knows what's really relaxing, but people call that the relaxation of the internal sphincter. People forget that the so-called internal sphincter is just a thickening of the circular layer of the smooth muscle of the bowel. And that, how do they know that is that muscle that is relaxing, or the skeletal muscle that surrounds the rectum, the voluntary sphincter? Nobody can answer that question. But in addition, people uses almost the same size balloon, regardless of the size of the colon. So we see patients with a giant colon that will require a balloon, a 1 liter balloon, in order to be stimulated. So, but they don't have that kind of balloon. So I don't believe in that kind of diagnosis. In addition, also people talks about anterior anus. An anterior anus, if you think about that, a real anterior anus should be a normal anus with normal skeletal muscle surrounded by skeletal muscle 360 degrees, with a pectinate line inside, meaning an anal canal, and located very much anterior. Well, if that's the definition of an anterior anus, I have never seen one. So the fact that I have not seen one doesn't mean that doesn't exist, but certainly makes that very, very difficult to explain, because I have seen thousands of patients, have never seen. On the other hand, I have seen many, many patients refer to me with the diagnosis of anterior anus, and actually they have a perineal fistula. Other people make the diagnosis of anterior anus based on the misinterpretation of an image of a constipated patient. Constipated patients, they have a megarectum and develop like a shelf, posterior shelf. And that posterior shelf makes it look like the rectum is coming down and the anus opens anteriorly, and there's a posterior shelf. That posterior shelf is just the image of a very dilated rectum above the voluntary sphincter. So that should not be considered evidence of an anterior anus. People make the diagnosis of puborectalis achalasia. First of all, I had never seen the puborectalis muscle, and I have never seen a picture of a puborectalis muscle. And I read, of course, thousands of reports of the so-called puborectalis, and achalasia means lack of relaxation. Again, those diagnoses are made based on the manometric principles, but I know because I did it, that rectal manometry is not a reliable study. And internal sphincter echalalia, again, I have never seen that internal sphincter. I have been looking for that, and I have never seen real pictures of that. It's described as a thickening of the smooth muscle, and I have been in that area hundreds of times and never seen that thickening. And so I suspect that the so-called internal sphincter is something similar to what we discussed many years ago. When we started seeing patients with gastroesophageal reflux, we talk about the lower esophageal sphincter. So we thought that the gastroesophageal reflux was a consequence of a malfunction or absent lower esophageal sphincter. And then we started looking for the famous sphincter. We never found that sphincter. So in retrospect, the lower esophageal sphincter is a physiologic concept, not an anatomic concept. In other words, you cannot see it. Perhaps it's an area where the smooth muscle contracts more than the rest of the esophagus. And something similar may happen in the rectum. But I have been looking for an anatomic representation, and I have never seen that. The person that you see here is Dr. Lester Martin. Dr. Lester Martin trained under Dr. Robert Ross at Boston Children's Hospital, and then about 10 years before me, and then he moved to Cincinnati, Ohio, where there were no pediatric surgeons. So it was the era, and when the general surgeons went to spend some time with Dr. Gross, and they become pediatric surgeons, and then moved to different cities in the United States, and were the pioneers of pediatric surgery. So that was Lester Martin in Cincinnati. He made a contribution in dealing with total canonical ganglionosis. But I'm not going to discuss the concept of the Lester Martin technique, because Dr. Bishop is going to discuss the specific subject of total canonical ganglionosis. I have the privilege to meet Dr. Lester Martin in Cincinnati. When I was there, I invited him to our hospital. He was very friendly with me, a very nice person. But basically what he did is to design a lateral anastomosis between normal ganglionic terminal ileum and leaving a long segment of aganglionic colon. And it's a tedious operation because you have to make a long anastomosis. But doctor, in retrospect, that looked like a significant contribution, but those patients eventually had symptoms and require a different type of approach. And Dr. Bishop is going to talk about that. Well, again, thank you very much, all of you, for having the patience to listen to my talk about the history of Hirschsprung disease. And if there are any questions that I can answer, it will be my pleasure. Thank you very much. Thank you, Dr. De La Torre.
Thank you, Dr. Peña. Any question for Dr. Peña, please? What is your opinion about 1 to 2 centimeters of the aganglionic zone that we have to leave in patients with endorectal pull-through, Suave or Swenson, and to preserve the dented line?
What's your opinion about leaving 1 to 2 centimeters aganglionic zone?
Which stand to preserve the dented line? Oh, yes. Is for me, the preservation of the pectinate line is something very, very important. And I don't believe that leaving 1 or 2 or perhaps even 3 centimeters of aganglionic bowel will represent a problem. I think those the patients with Hirschsprung disease who have obstructive symptoms, enterocolitis, constipation, or both of them, are not a consequence of a tiny piece of bowel with no ganglion cells. I think it's something much more complicated than that, and we don't know what it is. But I think that enterocolitis is a combination of a problem with motility and problem of the special vulnerable bowel to the invasion and translocation of bacteria, and requires if the young surgeons who are listening to me, you want to make a real contribution, study the problem of enterocolitis and Hirschsprung disease. And if you come up with an answer, you may win the Nobel Prize. So, but I don't believe it's a consequence of a little tiny segment of agar. That's too simplistic. That's my point of view.
What is your opinion about the Revain pull-through?
Oh, Revain pull-through. Well, I have a lot of respect for Dr. Revain, and I even keep a medal that was given to me with the name of Dr. Revain in Germany, and I was very interested in his history, and he was a great surgeon. But obviously, I was talking about 1 or 2 centimeters of aganglionic, not a big piece of bunch of bowel aganglionic. And what he did was something very simplistic, like an anterior, what the general surgeons call anterior resection, leaving a big piece of bowel. I met surgeons who claim that works. I'm not surprised, because many things happen in medicine that have no explanation, but I would never do that operation in one of my patients. Well, I will not have that opportunity anyway. I'm retired.
There's a very good question about why patients with anorectal malformation don't have a dentate line and anal canal, and they have bowel control, and why patients with Hirschsprung may become fecal incontinent.
Well, that's very, very good question. First of all, patients with normal sacrum, no tetracord, anorectal malformation with the what we call the benign type, like a perineal fistula, like a recto-urethral bulbar fistula, imperforadenous with no fistula, they don't have anal canal, and they have bowel control, but they are not perfect. They are not normal. We never claim that we operated on patients that made them normal like you or me. I suppose you are normal, right? I'm normal. But so if you, how do I know that? Because even under the best circumstances, patients with no anal canal and a perfect operation, if they have an episode of diarrhea, most likely they will have accidents. And why? Because they don't have the sensation to discriminate the difference between liquid and solid. So, but the patients with they don't have anal canal, but they have some degree of a different sensation that is called proprioception. The rectum is passing in a normal circumstances, or in patients with that kind of malformation, is passing through a cuff of skeletal muscle, voluntary muscle, is passing like that. So the distension of the rectum inside, if you put a balloon like in manometry in one of those patients in the rectum and suddenly inflate the balloon, they say, oops, I felt something. So they have that sensation. It's not exquisite sensation. The anal canal gives us exquisite sensation, which means we can discriminate solid, liquid, and gas. So a patient with an anorectal malformation may have sensation, and if the child is intelligent, they have bowel control, because they have the distension, they feel the distension of the rectum, they don't know what it is, and they go to the toilet. So that's the reason why those patients without anal, but they are not perfect. In Hirschsprung disease, if you damage the anal canal, you have no sensation, but you have another equally serious problem. We resected the rectosigmoid. Now, the rectosigmoid is the natural reservoir of the gastrointestinal tract. The rectum has a magnificent, extraordinary way to behavior. It catches the stool 24 hours under most circumstances, keeps catching the stool, distended, and doesn't contract. And that's why we are having a social life. We go meeting, we go shopping, we do everything, and we don't have to use the toilet every 3 hours. So at some point, involuntarily, the rectum decides that it's time to empty, and it starts contracting. And because we feel it first in the rectum like a little cramp, and then we feel when the rectum pushes the stool toward the anal canal, we feel what it is, and then we go to the toilet, and the rectum empties in a massive way. In Hirschsprung disease, we remove the natural reservoir. We are creating an abnormality in the patient. If I do a perfect operation in a completely normal individual, remove the rectal sigmoid and connect the descending colon to above the anal canal, the patient will experience lack of reservoir, meaning several bowel movements during the day. And if we resect more and more colon, the quality of the stool is becoming more and more liquid and less solid. And it's much easier, as you know, to hold solid stool than to hold liquid stool. So if you remove a significant portion of the colon, the patient will have no reservoir. So the patient has to learn to go to the toilet more often, and has to learn to control, to be more aware, and to control the stool even when it is liquid or semi-liquid. So if you remove the anal or damage the anal canal in a patient with Hirschsprung disease, and in addition, the patient has no reservoir, that patient is going to be incontinent. I hope I didn't confuse you. I hope I was clear in my response. If not, you can send me an email. We can discuss this later.
Thank you, Dr. Peña. Oh, I know everybody has very good bowel control, but probably you need to go to the bathroom. So we have a break, and we will be back at 11 a.m. Denver time. Thank you, everyone, and see you very soon. Ray, can you hear me?
I heard you. It's Gary.
Yes, I can hear you. Sorry.
Okay, so Ray, can you just put in your slide that we come back at 11?
Yes, I can. I can do that. Yep. I'll do that right now.
Yeah, thank you.
Yep.
And Ray, it's Carrie. I'm gonna try to go ahead and do it as a live presentation, but you can have my back one just loaded as in case something doesn't work.
Sounds good.
Because I kind of basically went through the exact same thing and just kind of took off the videos.
Uh-huh.
And then I'll pause during the question slides. And is that when you can throw up the poll?
Yes. When the poll comes up, I'll throw it up, and you'll just give people a couple minutes to answer the poll. And
I'll do like 30 seconds.
yeah, that's fine. Yep. Make sure people are awake.
That's right, because we got to keep moving because I don't want to talk too fast.
Yeah.
I know my presentation, the recorded one, I talk a lot slower. So I have to you can remind me, slow down. Or, hey, you're going too long and you need to wrap this up.
The recorded one we have it's not really recorded. It's just a bunch of slides with your profile on it.
Yeah.
Is that okay?
Yeah, have that one up. Yeah, because the slides have the recordings embedded in each slide.
Oh, okay.
Because that way I didn't have to record the whole thing at once because they kind of kept starting over.
Yeah, that's true. Okay. Let's take a look at that real quick, can we?
Okay. At mine or yours?
Mine. Let me put mine up real quick. Hold on. Okay.
Perfect. And so if you run that, so go to the next slide.
I can give you the slide control.
Okay, cool.
You should have that now. There we go.
Okay.
My objectives
Oh, there
for
we go.
today
Here
includes
you are.
number one,
Here I
how to
am.
build a good teamwork approach between the colorectal team and the surgeon, the radiologist, the gastroenterologist.
Okay.
So do you want to do it
Secondly,
this
I'd like
way
to
or?
explain our
No, can you
technique
stop
and the
that?
nuances of
Yes.
performing contrast enema examinations in children.
Aha. Okay. And so then this one. And can you see all of this?
No.
Okay. Oh, I have to share. Hang on.
Yeah.
Share. To share. Let's share.
So when we get to the poll slide, I'll bring up the poll thing.
Like that one.
Yeah.
And you can see this.
Yes, I can.
Okay. Okay. So I can start here. Let me see the chat side. I'm just making sure I can see the presentation
Yeah.
and the questions. Yeah, so there's the first one, like slide 3. Because I can do some of these a lot faster than I did. So I can have more time with questions.
Yeah.
Because they
that's
kind of
fine.
describe some of it.
Yep. So when you get to the questions, just go ahead and mention that's a question, recite the question, and then the answer set, the possibilities, the options.
Perfect. So I'm looking at my screen here to see. Now, if I try to see how to see myself, because it should be like a presenter view.
Yeah, you're not on, so your monitor is off.
Okay.
As soon as you turn that on, you'll be in the presenter view, and your face will show up.
Okay. Gotta close down a bunch of my other windows. Don't want something weird coming up. Oh, so I need to be in Zoom.
Carrie, just to let you know, everybody's hearing. So
Okay.
I don't know if Ray, if you can mute or put us
There's
in
no way.
a,
Nope, there's no way to do that. Nope.
okay, so that's fine.
So I should say nice things.
Oh yeah.
As
Okay.
always, as always.
Okay, now we can see you. Can you see yourself?
I don't.
You
So
Are you in the Zoom window?
I'm gonna um
And finally, to review the sensitivity and specificity of contrast enema.
um, yes, I have. I'm due in like 5 minutes and I'm running through, but I feel like I know what you're gonna do, so I'm gonna I just need to turn around and acknowledge you.
Hi, Gary.
Hey, how are ya?
Good. Are you ready?
We can do another minute.
Okay, let me know.
Are you able to see my screen and hear me okay?
Perfectly, yeah, you look great.
Okay, thanks.
I mean, the whole presentation looks great.
Is it right at 11?
Yep, I think we're ready to go.
Okay, perfect. Ready when you are.
Okay, I want to present Gary. Let me know when we are ready, Ray.
We're ready, let's go.
Okay. Hello again, everyone. Let's continue with this conference. Our next speaker is Dr. Kari Hayes. She is the Associate Professor of Pediatric Radiology here at Children's and is the Director of Pediatric Fluoroscopy and the Chairman of the Society of Pediatric Radiology Fluoroscopy. So she's going to talk about radiology in Hirschsprung. Thank you, Kari.
Thank you. It is an honor to be here with you and spend all this time watching and learning about Hirschsprung's disease sort of from the other side of things. So it is a great honor to be here and thank you for the invite. So no disclosures. My objectives are basically to discuss how we build a teamwork approach between the surgeon, the gastroenterologist, the radiologist, as well as the belt management team in order to better care for our kids. Second, I'm going to explain the technique and the nuances of performing the Hirschsprung's contrast enema for kids with Hirschsprung's disease and other things that look like Hirschsprung's disease, and then talk a little bit about the sensitivity and specificity of the contrast enema. So first of all, I'd like to know if any of you or all of you, if you could respond true or false, that I have a wonderful radiologist that my team works with in order to image my patients. So Ray's going to put up a poll and you just hit true or false. If you have a radiologist, that is good. Because I've heard some places don't have a radiologist who does pediatrics, or some surgeons have performed these on their own. Ray, do we have a good number? Okay, about half. So that's about 80 people each way. So I'm going to kind of give you, so if you don't have a good radiologist, sort of to understand what we know and what we've learned versus what I've learned from this amazing colorectal team over the past few years so that you can help educate your radiologist. First, you need to find somebody with passion, because why? If you have work without purpose, like if you just say, I need you to do an enema for no purpose, that's not fun and nobody will be engaged into learning. So work without purpose is punishment. Work with purpose, then you have your passion, and then you have findings. You find people that have passion, that can have enthusiasm towards what you're doing, and that inspires innovation and satisfaction, as well as creativity. So having that person around you is very helpful. How I started with this several years ago was I had a newborn baby with 2-day history of constipation that was sent to radiology, and the order was barium enema. So there are several things kind of wrong with this. One is that I didn't think 2-day-old babies had constipation. And I actually don't do barium enemas on any children, which I will discuss in a few minutes. This is what I saw, which basically kind of was my surprise of there was no anus. So I, as the radiologist, made the diagnosis of an imperforate anus and an anal malformation as the first one, because nobody looked in 2 days to see if this kid actually had an anus. So that's not what you want to do. So the clinical exam is the most important thing, as Dr. Bischoff was discussing. The order that I kind of created in our group was to have a contrast enema rather than a barium enema. And I'll discuss a little bit about that in just a minute. The history is really important. Are they premature? What's the gestational age? Have they had passage of meconium? This is the history to provide to the radiologist. Are they vomiting? Do they have bilious or non-bilious? Are their stools bloody? Because when you guys see a lot of them, they might come with the diagnosis already of Hirschsprung's disease, whereas we see these kids that all present the same. So having a little bit of history is helpful. One is that the radiologist is really not good at a physical exam in general. And so one of the topics that came up is the anterior position of the anus. And there were a couple of papers that came out saying that we on enema could diagnose an anterior position of the anus, but it is truly a clinical exam and looking at where the sphincter is relative to the opening of where the bowel is coming out. So I would say that in general, the radiologist is not as good at this as you are. And so having a ectopic anus or knowing that there's a fistula somewhere is very helpful to know. When we get kids with a history of abdominal distension, abdominal pain, possible Hirschsprung's disease, bilious emesis, any of these things, they're all categorized for us into a neonatal bowel obstruction when they're babies. We recommend a single abdominal radiograph, and we classify that obstruction as high, such as an obstruction in the esophagus, duodenum, proximal ileum, with the exception of the esophagus atresia, which may have a bowel gas pattern, even though there's a proximal obstruction. Then we diagnose a low or distal to mid ileum obstruction. And those we have many dilated loops. And the reason this matters is to determine whether we're going to do a contrast study from above to look for an obstruction or a contrast study from below. So the first thing we get is a X-ray in your patient who is presenting for possible Hirschsprung's or any of these other things with the same clinical presentation. The first radiograph demonstrates a double bubble sign, which is classic of a duodenal atresia. In that case, they can just proceed to surgery and don't need further imaging from a contrast enema. The second case has multiple dilated loops with minimal air in the rectum. For us, it's normal to not have air in the rectum for the first 24 hours. So just because there's no air in the rectum doesn't mean it's a Hirschsprung's. For our distal bowel obstruction, so we're going towards the Hirschsprung's direction, we're looking for the distal obstruction. So Hirschsprung's disease, which you guys are all talking about, and is one of our main diagnoses. However, the small left colon meconium plug diagnosis came up a little bit earlier about, do we biopsy everyone with meconium plug or a small left colon? Well, there is an association with Hirschsprung's disease of 3 to 38% of these kids will have a Hirschsprung's disease. However, small left colon may be more associated with prematurity or diabetic mothers or mothers who received mag sulfate prior to preterm labor. So if we have those histories, we may not immediately recommend a biopsy, or if they improve after the first enema, because most of the kids with meconium plug or small left colon will 80% will improve, and that contrast enema is considered therapeutic and diagnostic. So a lot of the kids will go on to get biopsied if they are having persistent symptoms. And so it's up to that clinical presentation again. So our imaging finding can look very much the same for a small left colon versus Hirschsprung's disease. So it is difficult for the radiologist to make that distinction on imaging alone. Meconium ileus, ileoatresia, and colonic atresia do look very different. So the next question is, should the contrast enema be postponed or delayed if the patient has had a recent rectal exam or rectal irrigation because concern of obscuring the transition zone? So yes or no, and I'll give you a few seconds. And the reason I asked this question, I had some colleagues that said, oh, they had a digital rectal exam this morning, I'm not going to perform the enema. So Ray, if you give us your question, so 50-50. So in radiology, the teaching was if you had rectal irrigations or if you had a rectal exam prior to the enema, that you may obscure the transition zone and that you should wait. And what we've actually found is I like having the irrigations prior to the enema because I feel like it differentiates better where the transition zone is for me in my experience. So if they're getting better with irrigations, that helps clinically, especially if they have enterocolitis, then the rectal irrigations are going to help them not be as sick. So we might postpone the actual contrast enema to look for that transition zone. I put together sort of this how to perform a contrast enema little picture because there's a few decisions that you make prior to performing the contrast enema. So the first thing is preparation of the patient. So in general, we do no bowel prep. Do we require them to be fasting? I will say no, especially in the neonate. When I do a contrast enema in an older kid with chronic constipation, I may have them fast for 2 hours or at least not eat a large meal because they can get very nauseated. So as you distend their colon with the contrast fluid, I've had a few kids that got very sick and vomited. So it's better to have them not have a full stomach. So the recommendation is not because it messes with our exam. It is so that they don't get sick when they're getting that reflux of the contrast into the colon. The second decision to make is what size catheter and contrast. We'll talk about contrast as well. So the catheter for the infants, we use somewhere between a 6 and a 12 French catheter. Usually I'll ask the parents if they've been having dilations or anything relative to that. So I try to stay smaller than the dilations. The 2-year-olds, up to 2-year-olds and more, I will tend to use a 24 French catheter unless they've had prior surgery and they've only dilated up to say 12 French. So asking the parents what they're using is very helpful. But in a standard full-term baby, I will use a 12 French catheter. In a preterm baby, I might go as small as a 6 French catheter. There are questions about taping and inflating the balloon or not, and doing hand injections versus gravity, and which type of contrast to use. So that first one is the prep. I don't require them to fast and I don't have them prepped, and it doesn't make me stop the enema if they've had prior irrigations. With regards to contrast selection, barium is cheap. So barium has no osmolality. It doesn't have iodine, and it is the least expensive contrast that we have. However, if it goes into the peritoneal cavity, it'll cause the granulomatous reaction and it stays there forever. So it also will become more powder-like and concrete if it sits in a colon that is not emptying itself. So if it gets dehydrated, it gets thicker and harder to evacuate. So I do have practices amongst my fluoroscopy committee in the Pediatric Radiology Society who do use barium and dilute it. I have chosen not to because I have the availability of these other possible water-soluble contrast agents that do cost a little bit more, but they are available to me and I prefer that. So if there was a perforation or there was a leak, then I'm not going to create the barium inside the peritoneal cavity. So VisitPake was one that is more expensive. There's Omnipake, there's Cysticonray, there's OptiRay, and then there's gastrographin. The most osmolar is the gastrographin. So to a normal kid with delayed Hirschsprung's disease presentation or constipation, we will do a 3-to-1 dilution with water and gastrographin and put that in. So it's partially osmolar for therapeutic reasons, as well as diagnostic. For the smaller babies, I tend to use the Cysticonray because it's closer to normal osmolality. So it's only minimally osmolar, and it doesn't cost quite as much. So it depends on your institution and where you are and what contrast you have available. So that's really sort of the most important part of picking your contrast. The American College of Radiology has this chart in it, and that's lists the ionic, and at the top there's ionic density, there's iodine viscosity, as well as osmolality. So this is where we go to find out what your contrast has. And that way, if you find one you like, you just kind of find it and see if you need to dilute it or not. When it comes to tube selection, we talked a little bit. Here were my different choices in radiology. Was the premature infant, I use the 6 French Foley, and I only inflate the balloon if I need to prevent leakage coming out. These other catheters in the middle were what I was initially introduced as the newborn catheter and the catheter that comes with the tip. I don't like either one of these. They're relatively stiff and hard. And then this is a 24 French Foley. So a couple years ago, I basically just switched everything to Foley catheters to make it universal for which catheters we were going to use for any enema. They are all latex free, and I don't inflate the balloon unless I need to. Some of the radiologists were trained that if you inflate the balloon, you could perforate the colon. I feel like that is very rare, and you can also inflate it under direct fluoroscopy imaging, so you can match the size of the rectum. Initially, we were taught to tape butt cheeks together in order to keep the contrast in. That gets very, very, very messy. But if you have a radiologist who's uncomfortable using a balloon on the inside, they can put a balloon on the outside and blow it up so you get a good seal and hold it. Or you can say just match the size of the balloon to the rectum so you don't get leakage. The hand injection versus gravity filling, I feel is, I use hand injection on most of the infants because you can get a 60 cc syringe and inject, and you can kind of feel the difference of pressure. And you can watch under fluoroscopy to see it slowly backfill the colon. So if you're experienced on what the normal pressure is, then that's something that you can do. I have several colleagues who don't want to use a hand injection because there are stories of having perforations. So they choose a gravity bag for larger volumes. And so there it becomes your comfort versus the radiologist's comfort. Most of us who do this very commonly will do a hand injection in kids under 6 months. So, is it considered safe in your practice to use a Foley balloon during a contrast enema in an infant? And if you could respond as a yes or no. And Ray? So more yeses than nos. And I think this is a philosophy that has changed over time. So even some of the top radiologists were saying, don't use a balloon as of even 5 years ago. So I feel like this is a movement as we have better catheters and better imaging to say it's okay if you match the size of the rectum. Thank you, Ray. What's that? This is a kid that was a 2-day-old transferred from an outside hospital with bilious emesis. So the images on the right, these three, are from the outside hospital. This is when they put a catheter in and you inject the catheter, and basically contrast is going all over the bed. It goes on the sheets. They're not getting reflux back. There's multiple filling defects that are in the colon. And so you can't tell if there's a transition zone because they could never get enough pressure to go backwards. So is this a small left colon? I don't know. Is this a Hirschsprung's? I don't know. Is a meconium ileus? I don't know. So we had to repeat that enema. In doing that, I put a small Foley catheter in with a small balloon, and we get retrograde filling of the entire colon, which is a little small. I use the diameter of the width of the vertebral body to call the colon normal. If the colon is bigger than the vertebral body width in the lumbar spine, then I say it's enlarged. And if it's smaller, then you go to a microcolon. So in this case, this is a small colon, and this is a case that was proved to be meconium ileus. Next is a 27-day-old male with constipation. My colleague gets this request and he kind of forgets that, oh, it's a 27-day-old, I should use a smaller tube. So he actually used one of the larger 16 French catheters, and then he inflated the balloon without looking. And so I've really said, hey, in these small babies, you'll be surprised that this 5 milliliter balloon will be very distended if you blow it up to just 5 mLs in a baby. So that's why I prefer to do it under direct fluoroscopy. But in saying that, when you let the balloon down, you could see the narrowing of the distal rectosigmoid colon, and then the transition is sort of more vague into the more proximal rectosigmoid colon. So this was a good example of if I blew up the balloon or if I gave the child a rectal exam, it's not going to make his his contracted bowel be not contracted anymore. So the Hirschsprung's pathology is still there, even though you may have stretched it for a second. It's going to go back and look like it did when it wasn't stretched. So I don't think that any of those other things that could make it look stretched actually apply. So I think that's a long-term radiology myth. With regards to the patient who presents, this particular patient represented at 28 months, and he had the diagnosis of Hirschsprung's disease, and he's got a large amount of stool. He had been getting rectal Botox. He had absent ganglion cells when he represented. So this is a post-surgical patient who had residual aganglionic segments in that distal rectal anastomosis. So in radiology, these things are kind of hard for us. So the features of Hirschsprung's disease in the enema that suggest Hirschsprung's is the transition zone, irregular contractions, irregular mucosa, and having a abnormal rectosigmoid ratio. So those are the 4 things your radiologist is looking for in the contrast enema to lean towards Hirschsprung's disease as opposed to the other etiologies. In this one, the child has a clear narrowing of the distal rectosigmoid colon. We measure the rectosigmoid index right in front of the sacrum and then up a little higher. So if the sigmoid is larger than the rectum diameter at distension, then we call that a abnormal rectosigmoid ratio, and we're concerned about Hirschsprung's. When the transition is lower in the rectosigmoid colon, we have a higher specificity of narrowing down that transition point. Anything more proximal really makes our transition zone very less specific. If we have positive enema findings on a contrast enema, the likelihood of Hirschsprung's from a clinical diagnosis of 13% will increase to 82% likely of Hirschsprung's if you get both together. So Hirschsprung's disease is always not diagnosed on the contrast enema, but putting things together will help you get there. One of these studies from 2015 in surgery said they took 158 contrast enemas and they looked at the transition zones, and there was a reader agreement about 89% on where that transition zone was. And they found that the post-test probability was, if we called it positive, 83% of the time we were right. It was inconclusive 32% times. And then the ones that we called negative that were false were the ones that have total colonic aganglionosis. So I will say the radiographic enemas are not good for total colonic aganglionosis. This is a particular example of a 7-day-old who had reportedly normal passage of meconium and at birth, and is now 7 days old and had bilious emesis. So we did the lower contrast enema. The distal rectosigmoid colon is clearly low. And there is a transition here, which I see more often when they're a little bit older. So this was rather prominent. And they went on to be diagnosed with Hirschsprung's disease. In another child was a neonate with distension, so multiple enlarged dilated loops. We go on to do our contrast enema, and this would be the microcolon. So in this case, this would be multiple dilated loops with meconium ileus and associated with multiple filling defects. So that's how we kind of differentiate the two by imaging. Another example of the kiddo who has dilated loops. They're 15 days old. We do a contrast enema, and there are meconium loops filling this back into the terminal ileum. So this is a case of a small left colon. So there was filling defects, and in this case, there was a diabetic mother. So when we can learn that different sizes, and if there's a clinical correlation, it's very helpful. Just another patient, multiple dilated loops. Here we have a contrast enema showing a very small distal colon. And this one was irregular contracted rectosigmoid colon with Hirschsprung's disease. And that shows the irregular contractions. The next case is a 16-day-old male with abdominal distension. We said high possibility of Hirschsprung's because there was irregular contractions, very similar to the prior one, but the biopsy showed normal ganglion cells, and this was later shown to be allergic colitis. So these are sort of the differentials when we have the contrast enema. A 2-day-old with vomiting, this was read as normal. I would say that this colon is a little tubular and a little tortuous for a baby, and there's several filling defects. So upon further biopsy, this was a total colonic aganglionosis. I had a colleague that read this particular one. So this is a 12-year-old with encapricis, and there was a very, very large amount of stool, very enlarged dilated rectum. And here is that quote unquote anterior position of the anus was called. And there was also called an ultra short Hirschsprung's disease. So this is a big place to raise caution in your older children that have chronically retained stool, that they tend to get dilation of that posterior pouch of the rectosigmoid colon at the rectal vault. And this can look anterior in position on imaging. So on a clinical exam, the rectum is in normal position. This is where there gets to be a lot of confusion. So it's an education part with your radiologist if you can explain that. Another case, this was an outside hospital that called Hirschsprung's. They did a biopsy that said there was no distal ganglia. So they did a pull through with a sigmoid resection. The child returns at 24 months post Swinson procedure, and he had multiple episodes of enterocolitis. And they asked for a repeat contrast enema, and he had a repeat contrast enema, and it showed this distal tapering and a large amount of stool right in that new rectal vault. He returns a year later And he has this picture, and we were wondering what was this, because there's massive distension of the colon. And this is actually a penny that was stuck in the distal rectum above that tight anastomosis. When they repeated the biopsy, it was normal. So they just continued with irrigations, and then the dilated colon goes down because they have recurrent bouts of the enterocolitis. So letting your radiologist know that is also very important. That dilation of the bowel can signal enterocolitis. This is a 3-day-old with bilious emesis, just another presentation, and they had diffuse dilation of bowel, and this child actually had enterocolitis at the time. But when we finished our contrast enema, there was this large filling defect. So getting that out helped, but he had persistent dilation. So the biopsy was done. And that's where he had the distal 13 centimeters of bowel that was all aganglionotic. This is a 6-day-old that had reported constipation. Showing another example. This one had a distal rectosigmoid Hirschsprung's disease, and there's thickening and irregular contractions. So the appearance of the distal colon can look very different, but still all present with Hirschsprung's disease. 3 years later, the same kid after the pull through had distension and had multiple episodes of allergic colitis. He had a rebiopsy with a full thickness biopsy, and it showed no ganglion cells. So he had an incomplete removal of the distal rectum with residual aganglionotic segment. So does the transition zone reliably delineate the aganglionic bowel in Hirschsprung's disease? The radiologist's agreement on the site of transition is about 90%. The concordance between the radiographic transition zone and the pathology extent of the aganglionic bowel is about 62%. The concordance is only 25% between long segment radiology findings and the radiology transition zone. So contrast enema for delineation of the transition zone in Hirschsprung's disease needs to be regarded with caution. It's especially true of long segment disease. This is something I really didn't learn in radiology, and it came about much later. So knowing this, I think, is very important and to share with your imagers. With regards to the different surgeries, I would say your radiologist in general does not know these, and having just a simple image like this can be very helpful when you're looking at the post-operative patient and deciding, okay, well, is this narrow because there's aganglionotic segments, or how is the surgery done? I think it's very helpful. So if you can share that with your team, that would be very good. Imaging of the post-surgical patients, we are really choosing to re-image if they have continued soiling, if they have continued constipation, or lack of spontaneous bowel movements. That's when we return back to the enema, and we're really looking for a dilated colon versus a non-dilated colon. This is a case of a 1-year-old boy who had a suave, I'm sorry for my pronunciation, and he had, it was tight. And so they went back and had to revise that because there was too tight at the end of the contrast enema. This is a 10-year-old male outside hospital with history of Hirschsprung's disease. He had a colostomy, and they said, evaluate for a stricture of the distal colon. On the outside images, this is the first. The second image looks like this. So you're wondering, okay, what happened? And this is contrast in the peritoneal cavity. So there was a leak from the distal pouch into the peritoneal cavity. When I saw this, my face is like, oh. This is why I don't like barium. This is days later, they went to do a CT, and you can see contrast all around the peritoneal cavity, encircling the bowel, and even going along the tract of the prior ostomy. So the question to me was, does he have enough distal colon left in order to revise the proximal ostomy? 2 years later, this is the X-ray that we're looking at. So this is all retained barium inside the peritoneal cavity. And this turns out to be very messy on the inside. So we did attempt to do a contrast enema, and all I could see behind that barium was this much bowel. And so he was deemed a non-operable candidate for a surgical revision. And finally, can the contrast enema help determine the site of location of the ostomy? You guys are talking a lot about that, which is nice. What I'm showing in this enema is that it is narrowed and irregular all the way up to the left hepatic flexure. So it's very important to have the ostomy in healthy colonic regions. And so that's what Dr. Bischoff and Dr. De La Torre are helping us out with. The anatomy of the distal rectum and the post-surgical evaluation is not part of normal radiology education. So knowing that is really important, because here we call a distal narrowing of the bowel, and he had 50% of the pectinate zone missing. And in general radiology, we won't really know what the pectinate zone is. So giving them a picture or a video is very helpful. And this is a 6-minute video that we had a link to earlier. And I feel that it's very important really for every radiologist or parent or patients to even look at it. It does a very good job at explaining. So in summary for me is the history and physical exam is really good coming from the ordering provider or the caregivers. Needing that information does help us sway to recommend a biopsy or not. To have a good working relationship with your surgeons, your GI team and radiologists to decide, like, are we going to do manometry? When are we going to do the biopsy? Are we going to do irrigation? So that everybody works as a team and tells the parents the same thing. The contrast enema transition zone is sensitive for the distal, rectal, and rectosigmoid regions. However, the contrast enema is not reliable in the pathologic transition zone in more of a long segment or total aganglionosis. And finally, my recommendation is to not use barium in pediatric colonic studies at all. But if that's all you have, it has been used with certain degrees of safety with dilution. And then there is a children's hospital video that they're giving you connections to watch things about Hirschsprung's disease. So thank you for your time, and I'm happy to entertain questions.
Thank you. Kari, you have some questions in the chat. One of them is, why do you use a catheter with a balloon if you are trying to catch a transitional zone?
So I prefer with the transitional zone and the balloon. So if the kids can maintain continence and they can maintain the contrast in where we're getting retrograde filling, then I don't necessarily inflate the balloon. If they're getting a lot of rectal leakage, then I will inflate that balloon to get a good seal, just enough so that they're not leaking through the exam. And when we're doing the post-operative imaging, I do a post-evacuation as well. So the kids that hold it too much, I let them go to the bathroom, and then we do the post-evacuation film to see, is it something they can evacuate or not?
Do you need a post-evac?
I think it depends on the clinical question. So if the question is, are they able to evacuate? Then absolutely. There are a lot of practices that don't do a post-evacuating film, and a lot of them will do a drainage. So they keep the catheter in and drain them out because they find that it is faster and cleaner and you have a better patient turnover. However, I have 3 different types of toilets in our bathroom. We have one for itty bitty kids. We have a stand that goes on a toilet, and we have a small like preschool toilet also. So the kids can feel comfortable in there, and then we can get extra information by seeing what they can get out. I don't feel I blow up the balloon too much to modify the anatomy of the pull through. If they're leaking, then you only do it to match the size that you can get the contrast to stop leaking. I know that there are places who do a contrast enema portably in the NICU population. That is not our general practice because we feel most of the NICU babies have just slow motility. And so they tend to slow feed them forward. And we do not do routine enemas on babies that aren't passing a lot of meconium because we know that their bowels are moving slow. But I know there are practices that will do portable contrast. It is not the general or the standard practice. With regards to false negative and false positives, yes, they're in the neonate. You can have allergic colitis, you can have just immaturity and the cells aren't evaluated. So by enema, you're not making the diagnosis. That goes to pathology. So you need the histology to make the diagnosis. Do we use contrast after Botox? You can, if you need to. The Botox is really just kind of trying to relax that area. Again, the information I also give is, can they retain the contrast? Are they fecally continent to fluid or are they not? Oh, how far does the contrast need to be in the rectum? I think, or the catheter. I feel like just years of experience, not really longer than their finger. Like the length of your finger is about how far you need to go because you need to be above the pectinate line and you need to be in the rectal vault in order to blow it up. So if you've blown something up farther in the rectosigmoid colon, you can absolutely miss a distal Hirschsprung's disease. They can also deflate the balloon though and see that there is contraction of that distal rectosigmoid colon.
What is your preference between IsoView and gastrography?
So IsoView costs more, is less has less osmolality. So the gastrographin is very good for therapeutic and I think imaging in kids. They used to say that we couldn't see the contrast as well on imaging because it didn't have as much density. But I find that on our newer equipment in the last 5 years, I can see them all fine. So diluting them, I use the older kids because they're less likely to have fluid shifts with the gastrographin. And I use the cystographin or cystoconray 2 that has an osmolality around 400 so that there's less fluid shifts associated with bringing in fluid into the bowel. I switch around 6 months to a year.
Okay. Okay, you can keep doing questions to Dr. Kari Hay. Somebody wants your contact information. You can type in the chat, Kari. Somebody wants to contact you directly. So you can put your email or whatever you want to place. We need to move forward. Thank you, Kari. Thank you so much.
You. More than happy to answer your questions. You guys can send me email if you like. Thank you.
Thank you. Okay, so the last conference today is Swenson, Suave, or Duhamel pull-through. I'm going to share my screen. Okay. Let me close this one here. Okay. Okay, so this is the last conference from this day. The idea of this 30 minutes, 25 minutes is to clarify something about the techniques, the most common techniques. We already know that there are more than Swenson, Duhamel, and Suave. We have the State, we have Ravine or Ravine, and many others. But sometimes it's confusing because currently, when you want to do an operation and you want to read papers, some surgeons, they are doing a combination of these techniques. So it is sometimes difficult to understand. And also, knowing the history of these techniques is very helpful when you need to do a reoperation or when you need to do a pull-through. So we call Swenson in many cases like a full thickness. When I was a fellow in pediatric surgery and for many years, we never mentioned full thickness pull-through. That doesn't exist in the past literature, I want to say in the last 10 years. So now many surgeons call Swenson like the full thickness. Duhamel has been always like retrorectal and Suave like endorectal. And I have seen many papers that they call Suave Swenson or Swenso Suave. So be aware of this terminology because it's confusing. Again, whatever is the Hirschsprung, whatever is the length of the aganglionosis, rectal, rectosigmoid, left colon, short segment, ultra short segment, or ultra short segment, whatever is, if the patient has Hirschsprung, the patient needs a surgical treatment. So if you make a question about what is the medical treatment of short or long segment, always is a surgical treatment. When we talk about Hirschsprung disease, and Hirschsprung disease is defined by the lack of ganglion cells. In other words, to confirm the diagnosis of Hirschsprung, you must have a biopsy of the rectum without ganglion cells. If the rectum has ganglion cells, if the rectum possesses ganglion cells, you can see the ganglion cells in the biopsy of the rectum. This patient, I don't know at this point what is the diagnosis of the patient, but Hirschsprung is not Hirschsprung, okay? So again, presence of ganglion cells is not Hirschsprung, even when it's an immature ganglion cells, few ganglion cells, rare ganglion cells, hypoganglionosis, whatever it is, but it's not Hirschsprung. Then, the main operation that is spread in the world, the surgical treatment of Hirschsprung, was the proctocolectomy or the proctosigmoidectomy, performed by Dr. Swenson and his colleagues. The original Swenson, if you want to talk about Swenson and you want to do a Swenson pull-through, a real Swenson, the real Swenson is you must, this is the initial image on the left, so you need to have the bowel, the proximal bowel. You need to close in like a Harman pouch, this segment. And then the sutures that you are looking here, you need to take it through the anus. You can see here like a forceps into the rectum. And then you need to prolapse the rectum. This is the real Swenson. Swenson did this operation in dogs. This operation was done before by other colorectal surgeons or other general surgeons for cancer, with patients with rectal cancer. But in children, nobody was able to do it. So he started to do this operation. What you are looking here is, this is the mucosa of the colon, let's say normoganglionic. And this line, very clear line, you can see here the hair of the dog, okay? This is the hair of the skin of the dog. This is the anoderm of the dog, the transition between the skin and the mucosa, and then you can see the line, okay? This is not the anastomosis. The anastomosis, Swenson marked the anastomosis with these arrows. So you can see these arrows here. So the anastomosis was here. And he was the first saying that if you do the anastomosis very close to this area, then the patient could have problems. That's the anastomosis. If you have experience doing this operation, an open operation, not laparoscopic, not transanal, you are going to be able to identify all the anatomy of this area, the skin, the anoderm, and the pectinate zone. Because the humans, we have a zone, we don't have the line, this line that was described by Swenson in dogs. In humans, we don't have this line. We have an area, could be 5 millimeters, 6 millimeters, 10 millimeters, depends on the age of the patient. If the patient is a newborn, this area is very, very, very small, millimeters. That's why it's more common to have patients with damage of this area when the surgeon tried to do a pull-through in a newborn. What was the complaint of this technique, the Swenson technique? Well, you already hear from Dr. Peña that this technique in other hands, not Swenson hands, produced damage of the urethra, damage of the vagina, damage of the many structures in the pelvis. So Duhamel, Bernard Duhamel, came with the idea, and this is the original paper from Duhamel, and he described to close the rectum like a Harman pouch, and then this is the colon with ganglion cells. You can place the colon with ganglion cells behind the rectum, and then with a special forceps, you need to leave this forceps for several days to create ischemia and then necrosis, and then this wall disappear. So you can create a wide window between the posterior wall of the rectum and the anterior wall of the normoganglionic bowel. Today, surgeons doing this technique, they use staplers. They don't use anymore this device. And then again, complaints and people not happy with Duhamel and Swenson were very enthusiastic with the Suave procedure. So Suave, as you already know, we have to do a mucosectomy. Always the mucosectomy in Suave starts from above, doing the mucosectomy some centimeters above the peritoneal reflection. This is the original image from Suave. And Suave described this technique using this diagram. So he described all the layers in the pull-through, the lumen of the bowel with ganglion cells, the mucosa, the submucosa, the muscularis, etc., and then the layers of the cuff to emphasize how you can identify this pull-through. The colon was left for some days, usually 20 days outside. This is a picture from Dr. Suave, and you can see here the colon attached to the skin here with some stitches, and then he went 20 days after to resect this portion, and this is the anastomosis. We don't know for sure if this patient will be fecal incontinent right now, but looks like in this picture. Then Boley, who was a pediatric surgeon in New York, he decided to create the cuff. You can see here the cuff, the circular layer of the rectum, and then inside he was pulling through the normal ganglionic colon and then the anastomosis, and this was the modification that many surgeons call suave volley procedure. Now, please look at this picture. This is very recent paper from 2022. This year is from this month, so it's a very recent paper. So a group of surgeons want to publish something very special, and I think it's very, very special. What you are looking here is the bowel with ganglion cells. This is another pull-through, and then the anastomosis and the cuff. You see the cuff here is the same operation like suave. This operation was described by an African-American surgeon in the United States. His name was Asa Jansi. This is the surgeon. And this is the original publication. It was years before Suave. I want to say at least 10 years before Suave. And it was, he called Swenson's operation, this one, and then the modification. So he left the rectal cuff and he did an endorectal pull-through. So in honor to Dr. Jansi, now you can find in the Journal of Pediatric Surgery the history of this surgeon. Again, his name is Jansi, and this is the original publication of this surgeon, dedicated also to Hirschsprung, and he did an endorectal pull-through. So the history changed every day. It's amazing. We already talked about the endorectal pull-through using the transanal approach. We are going to have tomorrow a complete conference about this technique. I don't want to stop with this slide. And then a modification or an additional technique using the transanal approach was the Swenson pull-through using the transanal approach. And this is the original picture published in the Journal of Pediatric Surgery in 2003. It was reported by Dr. Luis Martins from Brazil. And we can say this is the first publication of the Swenson or full thickness transanal pull-through. So again, these are the three main techniques you can call Swenson or full thickness, Duhamel or retrorectal. And now if you want to give honor to Dr. Jansi, you can call the Jansi Suave Volley. It's a tribute to this African-American surgeon. And this is the menu that we have already to do the pull-through in patient with Hirschsprung. So in the left side of the screen, you can read open, that means laparotomy, lap-assisted, or transanal only. If you want to do an open, you can do Swenson, Duhamel, or endorectal. If you want to do lap-assisted, you can do the technique first described by Dr. John Raffensperger, was the first surgeon that he performed a Swenson with laparoscopy. Then Tom Loeb was the first surgeon doing the Duhamel procedure using laparoscopy. And then Keith Georgeson was the first surgeon doing the endorectal using lap-assisted. These techniques, you can perform primary, as we already talked in the morning, or with colostomy in 2 or 3 stages. And then you can do transanal, Swenson, transanal, endorectal. Also, you can do primary or stage. So nowadays, we have many ways on how to treat patients with Hirschsprung disease. But the most important is you need to be very familiar with one of these, at least one of these. If you are doing one Hirschsprung every year or every 2 years, you need to be very familiar with one of these techniques. If you have more cases, I want to say at least 10 cases per year, okay, you can try different techniques. If you have to do a reoperation, nowadays, I think, it's my belief, if the patient has a complete anal canal, you can do a Duhamel, and you cannot risk the patient, to put in risk the patient on fecal incontinence after the operation. Why? Because this is a patient with Hirschsprung on the left side. So be focused just on this diagram. The green area is a patient, is the segment of bowel with ganglion cells. The red area, which is the rectum, is the patient, the area without ganglion cells. This is the Hirschsprung area. And then the anal canal. Remember, Hirschsprung affects the rectum and also the anal canal. In other words, the rectum and the anal canal are always affected in patients with Hirschsprung. Then, a good pull-through, or what we call good pull-through, is when you do the most of the resection of the aganglionosis, but you must leave some millimeters of the rectum in order to avoid damage of this orange area, which is the anal canal. If you do the anastomosis below the rectum, in other words, you resect all the rectum, you don't have any space to do the anastomosis with the rectal mucosa, then you must have to do the anastomosis in the anal canal. So you can produce some damage in this area. Could be partial or total damage of the anal canal. Is not uncommon nowadays. Thank you very much. Tomorrow we will have, we are going to talk about total colonic ganglionosis, which is another different problem. Also, we are going to talk how to approach patients with long segment Hirschsprung. We are going to talk about the anal canal, why it's important in patients with Hirschsprung, and the surgical treatment of constipation, and what we do with patients with colitis and postoperative problems. Thank you very much. If you have any question, please type in the chat and we can try to answer. Andrea, you can.
I didn't see questions. I was trying to
Okay.
monitor, but there are no questions so far. I think it was crystal clear.
Okay, perfect.
We'll
Okay.
see you all tomorrow.
See you tomorrow, everyone, 8 a.m. Denver time.
Thank
Thank
you.
you.